Call this meeting to order. Welcome everyone to meeting number 13 of the House of Commons Standing Committee on Health. The committee is meeting today to study the Patented Medicine Prices Review Board's guidelines, and then we will proceed to the clause-by-clause consideration of Bill C-210, an act to amend Canada Revenue Agency Act, organ and tissue donors. I want to thank the witnesses for appearing today. We will have Best Medicines Coalition, John Adams, Board Chair, Boehringer Ingelheim Canada Limited, Mahmoud Alibhai, Director, National Policy and Patient Access, Annie Beauchemin, Director General, Patient Access, Anne Beauchemin, Executive Director, Patient Access, Pricing, Healthcare Affairs Solutions, Canadian Life and Health Insurance Association, Stephen Frank, President and Chief Executive Officer, Independent Voices for Safe and Effective Drugs, Colleen Fuller. I would like to start the meeting by providing you with some information following the motion that was adopted in the House on Wednesday, September 13th, 2020. The committee is now sitting in a hybrid format, meaning that members can participate either in person or by video conference. All members, regardless of their method of participation, will be counted for the purpose of quorum. The committee's power to sit is, however, limited by the priority use of House resources, which is determined by the whips. All questions must be decided by recorded vote unless the committee disposes of them with unanimous consent or on division. And finally, the committee may deliberate in camera, providing that it takes into account the potential risks to confidentiality inherent to such deliberations with remote participants. The proceedings will be made available via the House of Commons website. And so you are aware, the webcast will always show the person speaking rather than the entirety of the committee. To ensure an orderly meeting, I would like to outline a few rules to follow. Members and witnesses may speak in the official language of their choice. Interpretation services are available for this meeting. You have the choice at the bottom of your screen of either Floor, English, or French. Before speaking, click on the microphone icon to activate your own mic. And when you are done speaking, please put your mic on mute to minimize any interference. A reminder that all comments by members and witnesses should be addressed through the chair. Should members need to request the floor outside of their designated time for questions, they should activate their mic and state that they have a point of order. Members should do likewise if they wish to intervene on a point of order that has been raised by another member. In the event that a debate ensues, the members should use the raised hand function. This will signal to the chair your interest to speak and create a speakers list. And in order to do so, you should click on participants at the bottom of the screen. When the list pops up, you will see next to your name that you can click raise hand. When speaking, please speak slowly and clearly. Unless there are exceptional circumstances, the use of headsets with a boom microphone is mandatory for everyone participating remotely. Should any technical challenges arise, please advise the chair. Please note that we may need to suspend a few minutes as we need to ensure that all members are able to participate fully. For those who are participating in person, proceed as you usually would when the whole committee is meeting in person in a committee room. Keep in mind the directives from the Board of Internal Economy regarding masking and health protocols. And should you wish to get my attention, signal me with a hand gesture or at an appropriate time, call out my name. Should you wish to raise a point of order, wait for an appropriate time and indicate to me clearly that you wish to raise a point of order. With regard to a speaking list, the committee clerk and I will do the best we can to maintain a consolidated order of speaking for all members, whether they are participating virtually or in person. Thank you all for listening to that long housekeeping speech one more time. Before I ask the witness to make a statement, I would like to advise the committee that we have received a letter from the law clerk indicating the status of the document production order. I would like to ask the committee for authorization to make this letter and its addendum public. Do I have approval of the committee to do this? Seeing no dissent, I thank you. The letter will be made public. So we will now continue with the witnesses. Witnesses will have up to 10 minutes to to make their statement. I will be using cards, a red card and a yellow card. Yellow card 1 minute before your time is up. And when you see the red card, your time is up. Please try to wrap up fairly quickly. So thank you all. So we'll start with Best Medicines Coalition. Mr. Adams, Board Chair, please go ahead, 10 minutes.
Chair and members, we appreciate your invitation to be here today, and we thank the committee and staff for their work throughout pandemic challenges. I represent a coalition of 30 patient organizations, national and regional, working together through the Best Medicines Coalition to support patients and advocate for better access to life-saving medicines. I volunteer as the chair of the board of directors of BMC. Our nonprofit supports any actions by governments, public or private insurers, and civil society that can deliver greater access to medicines for Canadian patients. We're a small but mighty organization made up of grassroots groups, including the one I lead, Canadian PKU and Allied Disorders, involving rare brain-threatening diseases, and broad-based charities. These groups involve patients and caregivers to improve care and are active in research, patient services, education, and issue advocacy. BMC member organizations include diverse conditions, including mental illness, arthritis, asthma, blindness, Parkinson's, psoriasis, and cancers, including breast, kidney, lymphoma, ovarian, and their survivors. I'm here today as a patient advocate because when our youngest child arrived, the miracle of universal newborn screening discovered his rare genetic condition, enabling immediate therapy. And as an adult, he volunteered for a clinical trial for its first drug, and that drug transforms his brain and life. His mother, my wife, died in 2014 of 2 neurodegenerative diseases, ALS and FTD, which still do not have effective treatments. It is a big deal when we can move lethal diseases like ALS from untreatable to treatable, and it is a big deal when we can permanently fix genetic problems, such as my son's, in the new era of cell and gene therapies. Let me address the important question of real, perceived, or imagined conflicts of interest. I happily completed the committee's disclosure form and want to address how the Best Medicines Coalition funds and governs its activities. We do not sell a service. We do not have union or other dues. We don't have university tenure or other job security. We don't charge patients to advocate on their behalf. To fund our efforts to support patients in the public interest, we will apply for that funding. This is not without precedent, as it exists in the context of climate change advocacy, telecommunications regulation, or legal challenges for human or charter rights. We ask HESA to recommend such public interest funding. BMC accepts funding from the pharmaceutical industry for our patient support activities. We make no secret of this and are aware of possible perceptions. It is why this funding is received with an explicit agreement that funding does not influence our policies, advocacies, or operations in any manner. All activities and interactions are pursued within a framework of integrity. BMC and its member organizations adhere to a code of conduct regarding funding, which is publicly available on our website. All initiatives are conceived and developed in and by the organization, aligned with its missions and goals, without influence from any funder on content, messaging, or execution. I'd be pleased to answer questions on this, and I trust that we all must be transparent about all our conflicts, perceived or otherwise. The matter at hand today is the government's approach on drug prices and the critical risk this poses to some Canadian patients. Our focus is ensuring that all Canadians have access to medicines needed when needed. Medical necessity is paramount for all patients. We support the need to make medicines more affordable for all patients, especially those who pay out of pocket. And we support the goal of actual prices in line with similar countries. We also believe regulations and guidelines must encourage, not deter, new medicines and vaccines, plus those clinical trials sponsored by drug developers, which are important to patient volunteers in providing early access to promising new therapies, as was the case for my son. There's a natural tension between how much insurers are willing to pay and patient access to medicine. Whether we like it or not, pharmaceuticals are a global market, and Canada is competing globally to be an attractive market. This is clear in terms of medicines, vaccines, and PPE. If Canada regulates prices too low, patients we represent will not gain access to life-altering or life-saving medications. If prices go too high, public insurance systems could become overwhelmed and unsustainable. This would be disastrous for patients and taxpayers alike. The challenge for Parliament, government, and PMPRB is to balance those interests, not an easy task. The government and PRP decided to move forward with their approach despite uncertainties on patient impacts. This is at the core of our concern. At this committee, PMPRB was unable to tell when certain conditions in the guidelines will come into effect. Consider a global entity is deciding on the sequence of product launches, and Canada's processes and pricing rules lack clarity for the foreseeable future. Why would it be a surprise that a new medication or indication would not be launched in Canada? This government is unwisely taking on significant risks, and the consequences will be borne by patients. We are not willing to provide informed consent. As written, the PMPR regulations and guidelines have not balanced price and access. Specifically, anticipated price reductions go beyond original intent, and initial evidence shows significant negative impact, a decline in new drug introductions and reductions in new clinical trials. This government confirmed the legitimacy of these concerns and, in my view, lost the moral high ground when it exempted COVID vaccines and drugs from the PMPR rules. Why COVID and not other lethal diseases? A frequent criticism is that few new drugs provide significant additional benefits to patients. COVID vaccines reveal this, but also show that it's not helpful. We have one approved vaccine today. It is a breakthrough. Other vaccines may be approved, but the others will not likely offer a substantial clinical benefit over that first approved vaccine. It's clear our health systems and individuals will benefit substantially from access to many approved vaccines, even if only the very first one is a breakthrough. This is how innovation works. A key marker for patient communities is whether medicines will be available to Canadians both affordably and in a timely manner. Since announcement of the new rules, applications for new drugs have declined compared to similar countries. This is troubling. Health Canada and PMPRB want to lower drug prices to reflect what the public health system is willing to pay or able to pay. Nothing in these changes makes certain health systems will deliver patient access to medicines at these prices. There could be a double whammy for patients. Price regulations might mean new drugs will not come, and if they do finally come, the system still may not cover them. We wish to express 4 recommendations for this committee to consider. First, the Best Medicines Coalition supports step-by-step limitation of lower drug prices. PMPRB indicated some phasing. They did not articulate when and what would be phased. We asked for clarity and decisions based on best evidence. We urge this committee to recommend that the federal government, through cabinet, direct a stay of implementation of parts of the regulations and guidelines, deferring the novel economic factors to a second stage, pending further study and consultation. The new basket of comparative countries should proceed to bring down list prices immediately, especially for those patients who pay out of pocket, which I point out represents 21% of all drug spending in Canada, out-of-pocket payments by patients. Second, the MC recommends this committee call for greater policy making disclosure, and we support any efforts of the committee to bring about that transparency. The government should disclose inputs provided as part of formal consultations and otherwise, including analysis of the nature and breadth of concerns and how concerns have been addressed or will be mitigated. Further, it is important that the government and PMPRB disclose correspondence and other inputs from provinces and territories. Thirdly, the Best Medicines Coalition asks that this committee recommend that the government develop and publish comprehensive evidence, including initial impacts on critical markers of policy success or failure. That is, key metrics of introductions of new medicines and initiation of clinical trials sponsored by drug developers. There is a need for disclosure regarding the government and PMPRB assumptions that the regulations and guidelines rely upon. We urge this committee to request that the PMPRB case studies on specific drugs back in 2018 prepared to show the impact of possible proposals be updated and published based on the final regulations and guidelines. Fourthly, the Best Medicines Coalition asks that this committee recommend that the government study and provide public interest funding so that the voices of patients, their needs and interests can be more adequately represented in public policy and regulatory matters, including PMPRB. I would be pleased to answer any questions. Thank you.
Thank you, Mr. Adams. We go now to Boehringer Ingelheim Canada Limited. Either Mr. Alibhai or Ms. Beauchemin. Please go ahead, 10 minutes.
Bonjour, bon après-midi. My name is
Good afternoon.
Mohamed, and I'm joined by my colleague, Mahmoud Alibai. Thank you, Mr. Chair and honorable members of the Standing Committee on Health for the opportunity and for inviting us to provide testimony today. We appreciate it, especially given the circumstances we find ourselves in. As we all know, the COVID-19 pandemic has truly transformed our society this year. We wanted to start by thanking you for all your ongoing work in the face of adversity, particularly your efforts to continue the important work that Canadians elected you to undertake in Parliament. Since Boehringer Ingelheim began operating in Canada almost 40 years ago, we've proudly played an integral role in the health of Canadians. Headquartered in Burlington, Ontario, we employ approximately 600 people across Canada, and we're committed to finding medical breakthroughs and investing in research, development, and medicine therapies which fulfill unmet medical needs. We were founded over 130 years ago by Albert Boehringer, and we strive each day to live up to the high ethical standards we set. Albert Boehringer set the tone for a company culture that we continue today that prides itself in supporting employees in our local communities, guided by our values of trust, respect, empathy, and passion for the work we do. Our vision is value through innovation. And simply put, this means we aim to find new ways to improve health and provide value by being innovative. We're committed to the development of innovative, cost-effective medications that fulfill unmet medical needs once again. Through our participation in medical and pharmaceutical research for both humans and animals, actually, and health system change projects, we have many of those, we contributed to the significant improvements in healthcare and developed innovative and cost-saving medicines. Our healthcare systems improvement projects are pharmaceutical agnostic, they're unbranded, and the Boehringer family actually mandates that we have these initiatives that focus on optimizing patient outcomes and improving health.
Excusez-moi, Monsieur le Président, excusez-moi.
Excuse me, Madame Beauchemin. There's been no interpretation for some time now. I do hope that won't happen again, but you'll see that I was unplugged for quite some time when Mr. Adams was talking. So hardware and logistics aren't working well today. So could you please look into that and see why I don't have any interpretation anymore? That would be very useful for me. Thank you.
Thank you, Mr. Theriault. Ms. Bushman, I wonder if you'd back up just a paragraph or two, and we'll see if the I'll stop your time. And we'll see if the translation is coming through. Yeah, go ahead, please.
Our vision is value through innovation. Simply put, this means we want to find new and better ways of improving health, and we provide value by being innovative. We are committed to the development of innovative, cost-saving medications that fulfill unmet medical needs. Through our participation in medical and pharmaceutical research for both humans and animals, and health system projects, we have a number of those ongoing, we've contributed to significant improvements in healthcare and developed innovative and cost-effective medicines. Our healthcare systems improvement projects are unbranded, pharmaceutically agnostic, and that's the Boehringer family actually mandates that we have these projects that focus on optimizing patient outcomes and improving health system efficiency, contributing to the sustainability of the healthcare system. In Canada, Boehringer Ingelheim conducts and sponsors clinical trials to establish the safety and efficacy of the drugs we develop. Our key therapeutic areas in Canada are cardiometabolic diseases, specialty care, including oncology, such as lung cancer and progressing fibrosing lung diseases, and respiratory diseases, such as asthma and chronic obstructive pulmonary disease. In a given year, Boehringer Ingelheim is involved in up to 70 clinical trials. And as you can imagine, 2020 has not been a restful year for us either. Since we understood what the world was facing with the COVID-19, we've been hard at work to understand the virus and create innovative ways to stem its catastrophic effects on our society and our most vulnerable. In addition, we've been actively testing existing and new compounds that can help to prevent or alleviate some of the devastating organ damage experienced by individuals who contract COVID-19. We're now in phase 2 of a therapeutic option that could help to up to 85% of our sickest patients afflicted with COVID-19 and who are admitted to ICUs with acute respiratory distress syndrome. Should the therapy be approved, it will reduce the need for ventilators among the most severely affected patients. As a company founded in 1885, more than a century ago, we've always taken the long view of our work's impact. We plan in generations and focus on long-term performance. Being independent and family-owned allows us to pursue that vision, which we believe in turn allowed us to have the greatest impact in life sciences. Independence also allows us to pursue initiatives and endeavors where we believe we can do the most good. It means we can focus on solving some of the most complex health problems our country faces and give us an opportunity to be involved in evolving the patient experience and creating lasting change. We've been involved in these system-changing initiatives for almost a decade in Canada. Unfortunately, none of the resources we've invested in these areas and in these projects are actually recognized by the Patent and Medicines Prices Review Board. For example, in September 2020, we were pleased to announce the creation of Bridging Hope, helping others through palliative care education, an industry-first collaboration with Pallium Canada to improve the quality and accessibility of palliative care in Canada. Together, we're equipping healthcare providers with skills and tools that provide better palliative care and support patients with life-limiting illnesses in their families, addressing an urgent need that will only increase as our population ages. Over to you, Mahmoud.
Thank you, Annie, and thank you, Mr. Chair, and honorary members as well. A further demonstration of our commitment to work with Canadians to solve problems and result in optimized outcomes. For the past 3 years, we've been working with an Indigenous-led health policy group to develop an Indigenous health policy framework. A number of you on the board have, I should say one has participated in this endeavor. A number of you have been briefed about the work we're doing with the Indigenous population. And this Indigenous-led, Indigenous-informed framework will guide, again, the principled approach that Boehringer will engage with Indigenous communities in partnerships in health system solutions, which, as Annie mentioned again, are pharmaceutical agnostic. That is the mandate of the family. So that again demonstrates our commitment. Our mission compels us to invest deeply in research and innovation to bring some of the most advanced therapeutics and medicines to Canadians. The latest regulations will jeopardize our ability to continue funding these innovative projects and research. Boehringer Ingelheim supports a sustainable healthcare system in Canada and invests heavily in R&D. We expect to bring new medications to market, and Canadians benefit from early access to life-changing medications through clinical trials, and thereafter as a prioritized country seeking regulatory review and launch of new drugs. However, the model that has enabled us to serve our patients for over a century is threatened by the final guidelines issued by PMPRB. Simply put, we believe that the guidelines will ultimately discourage or significantly delay the introduction of new life-saving medicines and investment in research and development, performing clinical trials in Canada, and the prioritization of Canada as a market to launch new medicines. This point cannot be ignored. The intent of the PMPRB will not matter if it ultimately creates less innovative medicines and treatments, less clinical trials, less innovative healthcare system change partnerships, and less access for Canadians. Intention needs to be met with well-considered, well-developed policy, and that is not where the PMPRB has currently landed with its guidelines. One of the central principles of the life science industry is a predictable process by which patentees can access the market for a drug, invest in research and innovation, and bring forward for approval to be given to patients that need it the most. The guidelines bring the PMPRB outside of its original intent as a patent abuse regulator and represent a substantial incursion into the exclusive provincial jurisdiction, namely price control. This process will undermine activities exercised by the provinces that today include input from patients and experts, but PMPRB will create significant uncertainty for any company considering investing time and resources into bringing forward innovative medicines. In keeping with the time, we urge the committee and the federal government to reconsider these guidelines and regulations that underpin them. The current guidelines are creating uncertainty and will create unintended consequences on business viability and therefore access to life-saving drugs for patients. Once again, Mr. Chair, honorary members, thank you for the opportunity to present and provide the briefing from Boehringer Ingelheim's perspective. We look forward to discussing this important topic, which will face the future of healthcare in Canada. Thank you.
Thank you, Mr. Alabhai. We go now to Canadian Life and Health Insurance Association. Mr. Frank, President and Chief Executive Officer, please go ahead. 10 minutes, please.
Thank you, Mr. Chair, members of the committee. Thanks for giving us the opportunity to speak with you today. Merci.
Thank you for having invited me to speak to you today within the framework of your review of the PMPRB guidelines. The Canadian Life and Health Insurance Associations is a voluntary association whose members hold 99% of the life and health insurance business in force in Canada. These insurers provide 29 million Canadians with products that contribute to their financial security, including supplementary sickness insurance.
The amendments that have been proposed to the Patented Medicines Prices Review Board, and they're coming into effect on January 1. Our member companies, which include nonprofit regional health insurers, provides prescription drug and other health benefit plans to over 142,000 businesses, large and small, across Canada. Over 26 million Canadians depend on these workplace insurance plans for benefits like prescription medications, dental care, eye care, physiotherapy, and mental health supports. With so many Canadians struggling and worrying about their family's health and security, now more than ever, Canadians want to know what they can count on. And Canadians with workplace plans want to know they can count on those plans to be there when they need them. We know that 87% of Canadians value their existing coverage. And moreover, we know that while all Canadians support smart reforms to improve the current system, they do not want it to disrupt their existing coverage. Depuis 9 mois,
For 9 months, we've been struggling with the COVID-19 pandemic, and insurers have been working with employers so that Canadians can still continue to count on their workplace plans. To help them to overcome this difficult period, employers have received direct aid that comes to several hundreds of millions of dollars, including in the form of rebates and deferrals on premiums. As with the health system in general, private insurance plans have been sorely tested as a result of the COVID-19 pandemic, and I'm happy to say that the workplace plans have stood the test of time. The health crisis has shown that these plans are resilient.
Of the 26 million Canadians who had coverage through their health benefit plans in March continue to be covered. Canadian employers and their employees continue to rely on these plans for a wide range of supplementary health benefits, as I mentioned above. But we cannot take this for granted, and rising drug costs have and will continue to be a strain on the sustainability of drug programs, both public and private, going forward. High and rising drug costs are a challenge that must be addressed. Currently, Canadians pay some of the highest prices in the world for patented medicines, and these costs put pressures on both employer-sponsored and government plans. And that's why the amendments to the Patented Medicines Prices Review Board are so important. Avec le temps,
over time, these amendments will allow us to better align prices in Canada with the prices that are practiced in other prosperous countries around the globe. This will lead to savings for provinces and Canadian employers, and these savings will make the programs more sustainable, but will also give them the capacity to cover new drugs coming onto the market, which are often very costly. It is not just a matter of helping public and private insurance plans. These reforms will directly lead to savings for people who have out-of-pocket expenses.
These amendments strike the right balance between reducing the high cost of prescription drugs in Canada while also ensuring Canadians have access to affordable and necessary medications. As I mentioned, our life and health insurers are proud of the steps we've taken to keep workplace plans in place and providing benefits for 26 million Canadians. Ensuring we pay a fair price relative to other developed countries is important if we're to sustain coverage for Canadians into the future and make fiscal room to cover the newer, expensive medications that are in development. Now, after consultations that have spanned several years, the PMPRP put forward their final guidelines earlier this fall, and Canada's life and health insurers are strongly supportive and urge members of this committee to support their implementation as planned on January 1. These are concrete and immediate measures that will lower patented drug costs for all Canadians and contribute to the future sustainability of prescription drug plans. Thank you for your time, and I'll look forward to your questions and the opportunity to provide additional detail to help your study if you have any questions for me later. Thank you, Mr. Chair.
Thank you, Mr. Frank. We go now to the Independent Voices for Safe and Effective Drugs. Ms. Fuller, please, 10 minutes.
Thank you, and many thanks to the Standing Committee for inviting our organization to appear before you today. I'm joining you from Western Canada, the beautiful unceded territories of the Musqueam, Tsleil-Waututh, and Squamish nations. Our group focuses on overall pharmaceutical policy, but many of us also have expertise in specific areas, including drugs to treat cancer, Alzheimer's, and other conditions. My expertise is in the area of drugs to treat diabetes with a focus on insulin. The first time I appeared before the Standing Committee was in 2003. I was part of a national campaign organized by a group called the Society for Diabetic Rights to fight for ongoing access to animal-sourced insulin products. I appeared during 2 days of hearings the committee conducted to study the issue. Insulin is sometimes called the poster child for pharmaceutical supply issues. Between 1995 and 2006, 26 different types of insulin were withdrawn from the market by Eli Lilly and Novo Nordisk, a move that left almost 45,000 people scrambling to find appropriate alternatives. That move had nothing to do with the safety and efficacy of the insulin products, all of which had been standard treatment since the 1950s and earlier. The withdrawals were part of a marketing strategy to force people to switch to much higher cost brands. At the time, and because of the work of this committee, Health Canada acknowledged that there was a significant minority of people whose lives and safety depended on ongoing access to animal insulin. And at the urging of the committee, the ministry worked and in fact continues to work to this day to ensure access. What this experience taught me is that there are two key barriers that patients confront when trying to access medicines. One is supply and the other is affordability. It's the job of the Price Review Board to ensure that the introductory price of new drugs is fair. Our organization supports the PMPRB as an important regulatory tool, and we've spent the previous year and more arguing for stronger guidelines. We were pleased earlier this year to see that the guidelines developed by the board took a positive step in that direction. While there's always room for improvement, we hope the committee will support the Price Review Board and in fact recommend that its role be strengthened even more. The decisions of the Price Review Board have a ripple effect across the country, and they either contribute to fairness or to inequality in access. As the story of Lantus insulin shows, which was part of the brief that we submitted, a decision that results in unreasonable prices for drugs shifts a significant burden to consumers as well as to public and private insurers. In the case of insulin, the overwhelming evidence showed that recombinant human insulins, which were introduced beginning in 1983, provided no additional benefit or significant reduction in harm compared to animal insulins. Yet prices skyrocketed, including after the founding of the Price Review Board in 1987. As Eli Lilly informed this committee in 2003, the introductory price of its beef pork insulin was $4.87 for a 10 milliliter vial of insulin in 1980. Then in 1983, the company introduced its recombinant DNA insulin, known as Humulin, at an introductory price of $12.50 for a 10 ml vial. That was a threefold increase in the price. Yet according to the Cochrane collaboration, which reviewed all of the evidence, Humulin offered no therapeutic advantage over its animal-sourced counterparts. Then in 1995, the first analog was introduced at a price of $30, another insulin product that was shown not to offer any therapeutic advantage over recombinant human insulin and by extension, animal insulin. Since 1987, the Price Review Board has approved the introductory prices of new insulins, and I would argue has allowed that price of insulin to increase, despite the evidence before it that patients not only don't experience a significant increase in benefit in terms of safety and efficacy, but also pay a price which is entirely unjustified. This is precisely why the tools available to the Price Review Board have to be strengthened. The ones affected the most by a weak price review mechanism are those who are usually the least able to carry that burden, meaning people who are uninsured or underinsured, poor, and in poor health. And of course, during this period when the COVID pandemic has been sweeping across the world, those numbers have increased. A recent survey of people with disabilities and chronic conditions found that the number of prescriptions for this group is 5, and the cost burden is between $200 and $3,000 per month. These are some of the people who need access to safe and effective and affordable medicines, and it is in their interest that the board should act when making decisions about what is fair and reasonable. Governments often say that after marketing authorization has been granted, they have no control over supply. I don't buy that, and I'm not alone. We believe governments have tools, and that if they don't have those tools, they can develop them. This is especially urgent now, in part because global pharmaceutical companies are threatening to stop supplying Canadians with new medicines if the guidelines go into effect. That is totally unethical. In response, we urge the Standing Committee to recommend that the House of Commons implement legislation to strengthen its compulsory licensing capacity and to establish a public manufacturer of drugs and vaccines. If Canada utilized its ability to issue compulsory licenses, it would mean that Canadians would no longer be vulnerable in situations in which patent holders are unable or unwilling to supply medicines. The Government of Canada could also work with other interested countries that want intellectual property rules in the WTO TRIPS agreement to be relaxed. For example, countries such as the Netherlands may be interested in developing policies that meet population needs while upholding obligations undertaken in the WTO. Compulsory licensing, or even the possibility of compulsory licensing, would shift some of the power over price from the patent holder to government, while at the same time protecting the patent holder's right to make a profit. This would strengthen negotiations with manufacturers over bulk purchasing of essential medicines and strengthen the role of the Price Review Board. And finally, Canada has a long history of publicly producing and supplying drugs and vaccines at cost to Canadians, including public and private drug plans, as well as consumers. Connaught Labs, where insulin was discovered and which became a major vaccine producer internationally, played a key role in the establishment of provincial drug plans, providing medicines and vaccine at cost. We continue to pay a very high price for the decision in 1984 to privatize Connaught. But if we can decide to privatize a Crown corporation, we can also decide to create one. And we urge the committee to include this in its recommendations to the House of Commons. The Patent Medicine Prices Review Board is an essential player in efforts to maintain some control over prices in Canada, especially since patents on medicines are granted for longer and longer periods. The new regulations and guidelines are a positive step in providing Canadians with more effective tools, but they aren't enough. The Price Review Board needs the backing of Parliament and Government of Canada to ensure it plays a role in supporting access to medicines. And Canadians need to trust that the federal government is using all the tools at its disposal to support access to safe, effective, and affordable medicines. And if those tools aren't there, that Ottawa will develop and implement them. Thanks again for allowing me to present our views and recommendations. And I hope that we've made a contribution to your discussions. I'm happy to answer any questions that you might have. Thank you.
Thank you to all the witnesses for your statements. We will start our first round of questions at this point. Monsieur D'Entremont, I believe you're up.
Thank you very much.
6 minutes, please.
Thank you very much, Mr. Chair, and welcome to everybody who's here today. And I want to wish everybody, if I forget towards the end, to wish everybody a Merry Christmas and, of course, a Happy Holidays as we move into it. I want to get to a sort of an issue that we keep talking about Canada having the highest prices of drugs in the world, or close to the higher level of drugs in the world. So since we have a drug company with us here today, maybe to Madame Beauchemin or Monsieur Alibi, is just how does pricing of drugs really work in a world context? You know, we talk about list prices, we talk about rebated prices. How do we actually rate compared to other countries in the world?
Yes, I'll take that question. Thank you for asking. The public prices of drugs in Canada are actually in line with countries that have similar GDPs and healthcare structures. And further to this, it's important to understand that there are significant rebates that are provided to provincial and federal drug plans currently. These are negotiated discounts that represent the drug plan's willingness to pay for the increased health benefits provided to patients upon assessment of the medication's value. And the cost of patented drugs in Canada is actually a small proportion of the total health expenditures. And they've actually been quite stable actually over the last decade in Canada with all factors considered.
When you talk about, and since you're at the mic right now, since you were talking about 70 clinical trials being held, are those just the ones in Canada, or are those clinical trials globally? How many of those
are in Canada?
Those are in Canada. How many of those are nearing completion, or are sort of maybe in sort of the list of, well, we're going to have to relook at these because of the changes to PNPRB?
Yeah, so you're asking about the impact we expect PNPRB to have on us. Yeah. So the first thing to understand is that we see a great deal of lack of clarity and uncertainty with the PNPRB process so far. We've conducted an assessment of what we assess to be the impact on our existing and upcoming products. And we've actually had to restructure and reduce our workforce. We can't share all the details for competitive reasons, but we've also had to reassess our current products and future launches, and we expect to make very difficult decisions whether we launch or not. And because of PNPRB, currently Canada is not viewed as a very attractive market to invest by global organizations, and we could see this get much worse if PNPRB moves forward with the new guidelines as they stand now.
Okay, my next question will go to Mr. Adams. So, you know, you talk a lot about different programs that might not come forward. Can you give us an example of within your group of partners? You know, how many studies or research projects or drugs might not be available, like within your groups? And I think I just lost him. All right, well, we'll wait for him to reconnect. Did I miss him? I'm just looking to the clerk. Have we lost Mr. Adams?
Let me check.
I've stopped your clock, by the way.
Okay, thanks.
He's not connected? No, he's not connected, so we'll try to reach him to see what the...
Okay, well, I can move on. I'll move on, Mr. Chair, to, I know we don't have a whole lot of time. So maybe Mr. Frank, before we can get back to Mr. Adams. So your organization is looking at these reforms as being very positive. It will save money for your members. How much of that money would go back into the hands of plan members or the like? I mean, will it bring down premiums or will it just keep the companies alive? I mean, I was trying to understand what you were saying in your presentation.
Well, thank you for the question. A couple points. Drug costs are borne by the employer, so the any savings on the price of the medications will flow directly through to the employer and ultimately to the employee. So that's not it's sort of a pass-through cost, okay, from our perspective. So the savings there would accrue directly into Canadians. And if I may just comment quickly on one of the other elements I heard earlier, I think it is correct to say that there are pricing negotiations occurring within the public system with manufacturers, but those do not apply on the private side. And so one of the advantages of an approach that would apply to everyone, and one of the things we find attractive about this, is PMPRB pricing does apply to all Canadians equally, which is an important piece for us.
Okay, thank you. So I see Mr. Adams is back, and I'm hoping he sort of heard the question, but the question revolved around with your partners within your coalition. How many examples do you have, or can you give us a couple of examples of research projects or drugs that might not be available because of these changes? Because that seems to be the majority of the presentations that we had received, or at least the briefs that we've received to the committee have been very negative towards the changes. And I think your group is a good representation of that.
Right. We have, among our members, we have two patient organizations in the cystic fibrosis space, but I'm going to speak about my direct personal knowledge. I have a son with a rare condition, PKU, phenylketonuria. He is on the first pharmaceutical, doing extremely well for that one. There is a second pharmaceutical for PKU, because the first one doesn't work for everybody. The second one has been approved in the United States 2019, approved in Europe 2020. No sign of an application in Canada. The same drug developer is taking that rare disease seriously. They have launched a clinical trial in Europe and in America, but not in Canada, for the first gene therapy for PKU. There's tangible evidence of at least a delay, if not a complete lack of access to, frankly, breakthrough therapies for the rare disorder. That affects about 2,500 Canadians, but it's one that I'm intimately familiar with, and there's no sign that drug company is going to make an application for either a clinical trial for the gene therapy, or for the second drug, or for the gene therapy, if, as, and when it proves to be safe and effective. So I would be happy. I would be delighted to do a follow-up with the committee with other tangible examples. It's not the only one, but it's the one that's very near and dear to my own heart.
Thank you, Mr. Dunton. We go now to Mr. Kellaway. Mr. Kellaway, 6 minutes, please.
Thank you, Mr. Chair, and to you and to my colleagues and the witnesses and the analysts and the clerk and all staff. Merry Christmas and hopefully you have a great holiday. And thank you for all the work you do, by the way. I'm going to start with Ms. Fuller. And Ms. Fuller, I've often heard the claim that lower drug prices will lead to a loss in R&D and manufacturing in Canada. And in fact, the countries that receive some of the highest rates of industry investment also have relatively low drug prices. So for example, Belgium receives 13 times the investment levels of Canada's, despite average prices being 20% or a little lower. Now, in comparison, pharmaceutical investments levels in Canada have been falling for the past 15 years or so, with Canada now having some of the lowest R&D investment and manufacturing activities in the developed world. So the question, could you comment on that? And can you comment on whether there's actually, if there's actually any evidence to suggest a correlation between the affordable drug prices and reduced R&D investments.
Thank you. Well, I think that your preface to the question sort of answers the question that companies invest in countries for, I'm sure, lots of different reasons, including the profit that they can make in that country. And the pharmaceutical industry undertook certain obligations in the North American Free Trade Agreement, as I'm sure you know, regarding their investment in Canada, and they have never reached the level of the commitment that they made in the agreement. I don't know all the reasons why they do or don't invest in a country. I think I think that there are both reasons to having to do with their profit levels. I know that in some countries in Europe that companies such as Sanofi, for example, have pushed back against regulations and price controls and have threatened to pull out of those countries, pull their production out of those countries. They haven't done it. So in spite of the fact that countries will implement stronger regulations and guidelines, they continue to invest. I think it has to do with lots of different considerations, and I'm not saying that I know what they all are. What I do know is that Canada has the capacity within our own country. We have the scientists, we have the capacity within our academic sector and scientific sector to do the type of research that's needed to support the development of drugs. And I'm not saying that we have to do it without the pharmaceutical industry, but I think that we have that capacity to do that, and that we frame the question as if we will not be able to do it if the pharmaceutical industry doesn't invest. So I question whether that's the case.
Thank you, Ms. Fuller. And I'm going to stay with you if that's okay.
Mm-hmm.
Okay. In written submissions to the committee, some stakeholders have expressed concern that the implementation of the amendments to the patented medicines regulation and the PMPRB guidelines will result in fewer innovative medicines being launched here in Canada. So 19 pharmaceutical companies have further suggested that the PMPRB guidelines are complex and confusing, which is leading to uncertainty in their decision making. As a stakeholder, what steps has the PMPRB taken to ensure that its guidelines can be clearly understood by stakeholders, and for that matter, for the general public?
I agree that the guidelines are difficult to understand when you just read through them. But I think that the period of consultation that was undertaken by the Price Review Board really enabled people who were involved in those consultations or who were observing them to understand what the impact of the guidelines could possibly be, what the rationale was behind the guidelines. I think that the Price Review Board did its due diligence to help people understand what the guidelines are intended to do. The pharmaceutical industry, including the companies that you just referred to, have entire legal departments at their disposal to help them understand what obligations they would be required to undertake if they complied with the guidelines.
Thank you so much, Ms. Fuller. How much time do I have, Mr. Chair?
You have just under 1 minute.
Okay, so I'm going to make it 3 for Ms. Fuller. So, Ms. Fuller, how will the updated guidelines make the process of industry stakeholder engagement a more transparent and an equitable and accessible process?
I'm sorry, I didn't quite understand your question. I'm sorry to take so much time.
No, it's okay. I'll repeat it again. How will the updated I don't think I said this in my question, so that might be the confusion. How will the updated PMPRB guidelines make the process for industry stakeholder engagement a more transparent, equitable, and accessible process?
Well, I think that some of the some of the guidelines on transparency will certainly, from my point of view, stakeholder enable me to understand a lot better what the rationale is on the part of the industry and in the assessment on the part of the board to either approve a proposed introductory price or not. I think that area of transparency is very, very important to bring some understanding to that. And I think that one of the things I'd like to see on the part of the Price Review Board, however, is a much more vigorous engagement with the Canadian public about the work that they do, what their intentions are, what their mandate is, in order for Canadians to better understand it.
Thank you, Mr.
Thank
Kilroy.
you, Ms. Fuller.
On va maintenant à Monsieur Thériault.
And now we'll turn to Mr. Thériault. Please go ahead. Thank you, Chair, and welcome to all of the witnesses. And my colleagues have worked very hard on this for several weeks and months. And I wish you all a Merry Christmas and a New Year that will meet your expectations. And with the vaccines in 2021, that would be a great gift. Now, Mr. Adams, on page 2 of your brief, right away, your organisation, which represents many other patient associations, has underlined that you support the principle of these price reforms, and you've said in particular by reducing prices so that they're in compliance with similar countries and more affordable for patients. So in your first recommendation, there's 2 parts to that. You're saying that there should be step-by-step implementation to lower drug prices immediately. And you're saying that we're inviting the Standing Committee to ask that the implementation of the new comparators, the new basket of comparator countries, should proceed to bring down list prices immediately for all patients. So under 1 and 2, you're saying that we're asking the committee to ask the government through the cabinet to actually ask for a stay for implementation of some parts of the regulations. For example, on the economic factors when it comes to determining the price and leaving that for a second stage while awaiting study and a more in detail study. Why have you asked for that in your recommendation?
On the first point, the people who are most suffering from drug prices are the patients who are paying out of pocket. That represents about 21% of the total spend on prescription drugs in Canada. And they don't have an ability to negotiate a better deal. The second group of people, and they're represented here by ably by Mr. Frank, are the private insurance carriers, and they, when they choose to have an ability to negotiate price on behalf of their plan sponsors. And then the third group are the government drug programs, which after 60 years have done the right thing and are bargaining collectively with with drug providers through an informal organization, the Pan-Canadian Pharmaceutical Alliance, which all the governments of Canada are participating in. So they are looking after themselves, the government drug plans, and they're doing a good job of it. The problem are the new factors. And the simple truth of it is that there is no other jurisdiction in the world that is using those economic factors for the purpose of price controls on drugs. Let me make the distinction between price controls by regulation versus price negotiations. And where individual patients don't have that clout. That's why we are in favor of the proposal and the regulation to change the comparison among countries. To countries that are of a similar capacity to pay gross domestic product. The economic factors, frankly, if the committee and its analysts could take the time to go back to the 6 case studies of 6 different kinds of drugs that the PMPRB staff put forward back in 2008 and which have not been updated with the final version of the regulations or the guidelines, you will see the problems there. And I would invite that a deeper dive by the committee and its analysts. Be happy to help them point to the right documents. It would be wonderful if the PMPRB had enough confidence in the rest of us that they would actually open their kimono and show us the details of their spreadsheets and their assumptions and their analysis so that we could be happy to verify or be happy to dispute. There has been a lack of disclosure by the PMPRB staff of what the assumptions are and what the actual details of their analysis are on those case studies. And with all due respect, color me skeptical when there is a lack of disclosure. Those are the reasons why we are concerned about the significant risk that the government and PMPRB are taking by proceeding with all of the changes at the same time. My last point is, let me use an analogy of a patient and a doctor. And no doctor worth his salt would knowingly start a patient on 4 new drugs at the same time. Because if something works, you don't know what is working. But more importantly, if something does not work, then you don't know what is causing the problem. The problem with these regulations and guidelines is trying to do 4 different things at the same time. So if something goes wrong, what is actually the central cause of the problem? So pause and reflect. Proceed with the change of basket of comparison countries, and let's take a deeper dive into the more likely impacts of each of the 3 additional new economic factors. Because this is an experiment in public policy that has not taken place anywhere else in the world.
Merci, Monsieur Thériault.
Thank you. Now for Boringer. I think I've got 1 minute left. So one of the founding principles. No, I don't have any time left at all. Oh, okay. It's finished. Sorry about that.
We go now to Mr. Davies, please. 6 minutes.
Thank you, Mr. Chair. Madame Beauchemin, if I understood your testimony correctly, you acknowledge that the pharmaceutical industry provides rebates to provinces. And we heard testimony from the PMPRB officials a few weeks ago that part of the changes will require transparency so that they have a better understanding of what the real prices are in the marketplace to help them set effective pricing for Canadians. Do you oppose that requirement to have pharmaceutical companies transparently reveal the rebates that they're giving?
Well, let me take you through the process.
No, I don't want you to take me through the process. I just want to know if you oppose the requirement for transparency.
This will answer. This will get to what you're referring to. So I think it's really important to understand the original intent of the PMPRB was to prevent abuse of excessive prices, and what's happening here goes well beyond this. Our concern is the guidelines create a great deal of uncertainty, which will actually prevent life-saving medications from coming to Canada. It is in the jurisdiction of the provinces to negotiate prices. The way the process works now, the PCPA, which is an alliance of provinces, negotiates with companies like ours based on the value that's assigned to a drug based by an assessment of experts.
I'm sorry, Ms. Bushman, I have limited time. I'm sorry, I'm not going to let you take time to explain things. I want an answer to the question. The question is, I understand there's rebates given by pharmaceutical companies.
Yes, and
they don't seem to want to reveal those to the PMPRB, which results in a skewed idea from the PMPRB about what the real prices are. Do you or do you not support transparency in the rebates?
Those rebates are confidential based on negotiations with the province.
I understand. Okay. Mr. Alibi, you mentioned that you thought that you made a claim that you thought the PMPRB changes would reduce clinical trials in Canada. What evidence or data do you have to suggest or to support that? And would you provide that to the committee? Mr. Alibi? I'm sorry, Mr. Chair. Can you please stop the clock? I don't know where maybe Mr. Alibi is.
Sorry, I was Sorry, I was muted on that. My sincerest apologies.
Sorry, I have stopped the clock. I'll restart it in a couple of seconds. Thank you. Go ahead, Mr. Alabama.
Thank you for that question, honorary member. All you have to do is take a look at what's transpired since 2018, when the PMPRB guidelines were initially put out. From the perspective of clinical trials and from the perspective of new drug launches in Canada. 21 of 34 drug launches, of 34 launches globally, 21 of those drugs have not been launched in Canada. And these drugs represent rare disease oncology products. Beyond that, honorary member, if you take a look at the clinicaltrials.org website, where all clinical trials have to register on that site. It's a federal website. The number of clinical trials in Canada has dropped significantly once these guidelines were put out. So all you need to do is take a look at what's transpired since 2018, and the data is there.
So you're basing this on the fact, obviously the PMPRB changes are not in force. So you're saying that the mere possibility of PMPRB changes have caused pharmaceutical companies to decide on their own not to launch clinical trials in Canada? Is that what you're saying?
Thank you for that question, honorary member. The pharmaceutical industry plans long-term, 3 to 5 years, in the clinical trials that we establish in any jurisdiction, in the kind of health system partnerships we establish in Canada, in patient support programs to take care of patients who may fall between the gaps. The guidelines have resulted in significant unpredictability, significant uncertainty.
Can I jump in and just suggest, Mr. Alibi, that it's going to result in reduced profits for the pharmaceutical companies? Would you agree with that?
I would say that if you take a look at the submissions that the patient organizations have made.
No, I'm asking about the pharmaceutical companies. Is it their concern, sir, that they're going to have reduced pharmaceutical profits if the PMPRB changes come into effect? Is that a fact or not?
Thank you for asking that.
Our concern is we will not be able to bring life-saving drugs to Canadian patients.
And profits have nothing to do with the issue? Is that what you're saying?
No. If I could share with you, Mr.
Well,
Davis.
I think there was a letter that recently was sent by the pharmaceutical industry to the Canadian government that offered to pay $1 billion to the provincial or to the federal government if they did not proceed with the PMPR changes. And I think they estimated that they would lose $10 billion over the next 10 years. I'm going to turn my next question to Mr. Frank. Mr. Frank, you've correctly pointed out that the PMPRB changes would result in reduced costs to employers in this country. Do you have any idea of the estimated cost savings to employers in this country from the PMPRB changes?
Well, we have to base our estimates off what the PMPRB's estimates are. So it'd be somewhere in the savings to employers would be somewhere around 10% of what's spent currently, which is a significant amount of money. It'd be in the billions of dollars over time that we would expect to be passed through to employers, and that would let them, like I said in my notes, allow the capacity and the room for them to even contemplate providing funding for these new medications. The envelope is getting full, and the idea that there's even the capacity to pay for some of these new medications if we don't make some room on what we're already covering, I don't think is correct. We do need to address the prices in order for us to be able to even contemplate some of these new therapies.
Thank you, Ms. Fuller.
Thank you, Mr. Davis.
Oh, sorry. Thank you.
So that ends our first round. We'll start our second round with, once again, Mr. Dantemot, I believe. Mr. Dantemot, please go ahead, 5 minutes.
Thank you very much, Mr. Chair. And I had a bunch of questions, but I need to go back to this. And maybe this is for Boehringer and maybe others. I look at, we talk about the importance of drugs in our healthcare system, the availability of therapeutics. Why does it seem that drug companies have become the big bad wolf in all of this discussion? Why do governments seem to have to push back on pricing all the time? Is there a disconnect? What have we missed over the last number of years? And it's probably best for Madame Beauchemin or Mr. Alibi.
I will leave it up to Annie. Did you want to address that?
I think the issue is here, we've spoken about our organizational mandate and our values, and we are a company deeply focused on patient needs. And we're here to represent the fact that the issue with the regulations here is that the original intent of the PMPRB was to prevent abuse of patented drugs with respect to excessive pricing. But what's happening now is these guidelines go well beyond this. You've heard multiple times by multiple people here today, they're highly complex. They have created a great deal of uncertainty, and they will make it difficult for companies to make a sustainable contribution here to commercialize medications in Canada. So I think that's the heart of the matter for us, and that's our concern for being here, member.
Okay, thank you very much. Maybe even back to Mr. Adams for a second, and you brought it up in your opening statement when you talked about whether organizations are taking money from pharmaceutical companies, as that's a bad thing. But one of your recommendations is to, if I just dig it up here, one of your last recommendations was sort of to create some kind of funding for patient groups so that they can speak on behalf of their organizations. Maybe can you talk to that one just a little bit more?
Delighted. Thank you very much. I'm a volunteer there are a lot of patient organizations where the desk is the office is a desk in somebody's bedroom, and that applies to our little PKU group. So it's a very big deal to try to engage with PMPRB, and I'll use them as one example, it's not the only one, in order to understand their processes and understand when the appropriate opportunities or lack of them for the patient voice, the unique perspective of patients as the users of prescription drugs to engage in the process. And I think there's lots of opportunity for improvement of that in the PMPRB and its processes. But there are other aspects of the healthcare system. The initial regulatory review by Health Canada for safety and efficacy and quality of manufacturing. That's very time consuming. And then there's the other phase, the health technology assessment process. And there is a window of opportunity now for patient individuals and groups to make submissions into that. But that's a huge burden of effort for many volunteers in many of the smaller patient organizations. And it would be very, very helpful. And I think it would improve the quality of the process and protect the integrity of each of those processes, the price review process, the safety efficacy review process, and the health technology assessment process, if the patient voice was strengthened.
All right, thank you very much. And I know I didn't really get any questions to Ms. Fuller, but and maybe a quick one to her, because I know I'm running out of time. I got about a minute left there. But how could the industry work a little more collaboratively together? I just look at how R&D is done across the country. Is there a better way to be doing it, or is the suggestions from PRB the only or just one step in that process?
When you say the industry working together, do you mean with each other or with the board? Or
well, I would say the industry together, because what we see is pharmaceutical companies that seem to be put to a side. They've got their own way of doing things. We've got universities that seem to be doing their own thing. We've got companies and governments that want to have a piece of that. So I'm just wondering if there's a better way for some of these things to go. And I know I ran out of time there.
Am I able to answer the question?
Yeah, please be quick if you can, and
Sure.
then we'll move on.
I think that there's remarkable cohesiveness amongst across much of the industry. I think that they act in concert. They are members of a large organization that lobbies on their behalf, and that is threatening to pull out of Canada or not supply drugs in Canada if the guidelines go through. So I think that they do. One of the things I would like to mention is that on the issue of investment in R&D, a lot of that the significant drop, as one of the witnesses said, since 2018. This is a drop that didn't just suddenly happen in 2018. It's been going on for a while, is my understanding. Maybe I'm wrong about that, but that is my understanding. And that the industry has never lived up to its obligations under the free trade agreement to invest in research and development. To think it's about 10% of profits. And so all of this about the guidelines is one thing, but they've never stepped up to the plate in the way that they were committed to doing in the past.
Thank you, Ms. Fuller. I'm going to have to cut you off there. Thank you. We go now to Dr. Pawlowski. Doctor, please go ahead. 5 minutes.
Yeah, I'd like to follow up on Mr. Davies' question. Mr. Alibahai, I hope I'm pronouncing that right, has said that a whole bunch of new drugs haven't come onto the market in Canada or asked for approval by Health Canada in the last couple of years. He's also said that the number of drugs undergoing clinical trials in Canada has gone down.
Monsieur le Président, il y a un problème avec la traduction.
Mr. Chair, there's a problem with interpretation. The volume from Mr. Pawlowski is very low, and they are unable to provide service.
Dr. Pawlowski.
Yeah. Sorry, the fault is completely mine. Plug mic.
I was following up on Mr. Davies' questions.
Just hold up here. Just say a few words for the translators to make sure that we have you properly on sound.
Hello. Merry Christmas to all. If I don't get around to that, I hope you have a great.
Okay. We're good to go. I'll start your clock again now.
Okay, I wanted to follow up on Mr. Davies' question. Mr. Alibahai, I hope I'm pronouncing that right, has said that in the last couple years, there's been a significant drop in the number of new drugs, either asking for approval from Health Canada or coming on the market. He's also said in the last couple of years, there's been a significant decrease in the number of drugs that are in clinical trials in Canada. And he either said or implied this was a result of the uncertainty arising from the proposed changes to the Patented Medicines Prices Review Board. He can correct me if I'm wrong on that. But now I'm not a big opponent of pharmaceutical companies. I realize that in order to encourage research, pharmaceutical companies have to be able to recoup their costs with the development of new drugs. But I'm sorry, with the decreased number of drugs getting on the market, the fact that there are drugs being approved elsewhere but aren't even being brought before Health Canada for approval, you're not bringing your drugs to Canada for clinical trials. It looks to me like you're holding sick Canadians for ransom because you want to prevent these new changes going through in the Patented Medicines Prices Review Board. And I have to say, this is not a pretty picture for the pharmaceutical companies.
Thank you for that question, honorary member. There's a process in place in Canada that has been in place for 10 years that the provinces have implemented, which is called, as you are aware, the Pan-Canadian Pharmaceutical Alliance. Boehringer Ingelheim was the first company that went through the successful negotiation on the PCPA process for a stroke prevention drug, the first drug in 50 years that demonstrated improving stroke outcomes. We built the negotiation framework with the provinces. That demonstrates our commitment to ensuring Canadians access. Subsequent to that, we've been through 17 successful negotiations. Paramount, honorary member, there is a process in place that has been in place for 10 years now that falls under the provincial jurisdiction of pricing negotiation that has worked really well and has led to Canadians receiving access to innovative treatments. The federal government has joined the Pan-Canadian negotiation as they see how effective it is. So the substance is there is a process in place in Canada what is being proposed by PMPRB oversteps respectfully its jurisdictional boundaries as a patent abuse regulator and circumvents the provincial jurisdiction of price negotiation, which has demonstrated to be very effective.
With all due respect, I don't think you're really answering my question, which is, it certainly looks to me like the fact that the pharmaceuticals aren't asking for Health Canada approval for their medications is a brazen attempt to get sick Canadians to start advocating on the behalf of pharmaceutical companies to get in changes which will basically allow you to maximize your profits in Canada. That's the way it looks like to me. And I've got no big chip against pharmaceutical companies, but that's the image you're giving, I think, Canadians. And I'd like you maybe to respond to that. If that isn't the image, if this isn't true, then why isn't it true?
As any business, honorary member, you require certainty and predictability over a 3 to 5 year horizon. Introducing a drug in Canada requires investments in clinical trials, requires more than just getting a Health Canada approval. And what has happened with the PMPRB regulations is that it impacts the predictability and the certainty of the business model to ensure that beyond just introducing a product, we can ensure that the product supports clinical research on an ongoing basis and that the product supports some of the kind of initiatives from a health system perspective that we've spoken about and patient needs for the long term.
Thank you. Maybe I'd like to address the question to Mr. Adams. I know you advocate for patients. Am I totally wrong in my perception of what the pharmaceuticals are trying to do here?
I think there are, let's be clear, there have been some bad actors among about some pharmaceutical company executives who have abused market power in some situations. There are notorious examples of that. But with respect, they are not necessarily representative of all of the companies by any stretch of the imagination. I'm going to do an analogy, and it may make some people uncomfortable, but there have been allegations of parliamentarians not having appropriate behaviors to certain forms of their staff. That isn't to say that every one of you on this committee is a sexual predator. So yes, there can be bad actors, and they deserve to be taken to task. And I think there are ways and means of doing that. On the other hand, I think some of the criticism comes from a point of view where we do not have regard for, I will say it, a commercial business or profit-seeking motive. And there's all kinds of, there are patients who share that value judgment, and there are patients who come from senior business executives.
Thank you, Mr. Adams. I think
so. That's all I can say.
Okay. Thank you. Thank you, Doctor. We go now back to Monsieur Dantemont. 5 minutes, please. Monsieur Dantemont, go ahead.
Sorry about that. I was thinking it was the NDP's turn. Not that I want to give my time to him, but I'd be very, very happy to do that sometime. Or even look, listen, I know we've been going around and around this one a little bit, but we keep hearing the same thing. So let's go back to what we're hearing mostly from patient groups. And I think this is probably for Mr. Adams again. We keep hearing from those patient groups that they're worried about that lack of access. And I know you had a really great example when it came to the drugs that your son might be able to receive. Do you have many other thoughts for us before we finish up today of other organizations within your coalition that might not have a big enough voice to get before us, that their story might not need to be heard? And I know Trikafta seems to be the one we use the most here. but are there other examples like that?
Well, if I may, I'm going to use the example of ALS. As you know, one of your colleagues in Parliament, you watched him live through the disease and the finality of that incursion as I watched through my wife go through it. I want to put in a plug here for some wonderful folks at Health Canada. There was a drug out of Japan that slowed down the progression of disease. It did not change the course of the disease. It was not available in Canada. And we have a tradition of allowing individuals to bring in by personal import a 90-day supply of a drug that's not available in Canada. And that's a real problem because there's lots of drugs that are not available in Canada last year or already, separate and apart from the discussion about PMPRB. It was a big deal to go to Japan and bring a 90-day supply. And Health Canada reinterpreted the rules in a very humanitarian way and allowed people, they didn't have to go to Japan, they could ship it, and they could ship in a 180-day supply. That drug company from Japan came to Canada, went through the process. The good news is the drug is now available in Canada, but they could not come to terms with PMPRB under the old rules, not the new rules, the old rules. So they did a really unusual thing. They allowed their patent to lapse. So they have fled the jurisdiction of PMPRB. The good news is that drug, it's not the greatest drug in the world, but when you're dealing with ALS, you'll take faint hope. My concern is, given the additional barriers to reimbursement and patient access, that when there is a breakthrough for ALS, like we've had for COVID-19, that Canada is going to be even further back on the list of when ALS patients don't have very much time for process. They need help ASAP. And I use ALS, but there are lots of other diseases that have no useful therapies or not adequate therapies today. And that's with respect, I'm not prepared to wait for governments to pay for all the R&D that will bring a breakthrough molecule for ALS or anything else. We need investors in the private sector to be partners in this. And please, we ought not to be in the business of kicking sand in their face. Thank you very much.
Okay, thank you, Mr. Chair. How much time do I have left in this round?
You have a minute and 12 seconds.
A minute and 12 seconds. Listen, I know Mr. Terrio wanted to ask a few more questions, but I know he doesn't have a whole lot of time, so I'm going to pass my time to Mr. Terrio.
Merci, c'est gentil.
Thank you, Mr. Tantima. Go ahead.
Thank you very much. It's very kind of you. So the executive director from the board, Mr. Clark, said, and I'm quoting him on November 27th, I don't think that it is up to the board to make sure that all these guidelines, these regulations actually are in favor of R&D. And later on, when I was telling him, so what do I understand is like over the last 5 years, the board has not carried out analysis of the economic consequences in terms of life sciences. And he said, well, yes, we have not analyzed the consequences on the sciences of life, but we have carried out analysis on cost and price, and we believe there will be no consequence. Well, I don't know, Mr. Adams or Boringer, when you said that the reform that has been suggested by the board actually negates one of the basic principles of life sciences, because the process has to be predictable, and it is through a predictable process that the patent holder can then, assess the market and then invest in R&D. Are you surprised by this type of answer that was provided? You are on mute, I think. Yes, indeed, Ms. Beauchamp, a quick answer. We do not agree. We are convinced it will have a negative impact. And the way the process takes place right now in negotiation with the provinces, there are some important rebates that are granted. And we do believe strongly that with these new guidelines, will go above the provincial jurisdiction. So it's important to take this into account. Thank you, Mr. Thériault. For Mr. Adams now. In your brief, Mr.
It's up. You'll have you'll have 2.5 minutes shortly. We go now to Ms. Sidhu. Ms. Sidhu, please go ahead. 5 minutes.
Thank you, Mr. Chair. Maybe this is the last sitting of our committee in 2020. I want to thank my colleagues and committee staff for their incredible work. Happy holidays. A brief observation from the insightful discussion from the comments of one of the witnesses today. I strongly believe that Canada's economy and Canada's healthcare market is one of the most stable and predictable market in the world. Through you, Mr. Chair, to Mr. Frank. I talk to my residents every day. The issue of drug cost and reliable insurance comes up in many conversations. As we all know, the government is working to move forward in establishing the fundamental elements of Canada's pharmacare. I often hear from my residents about the high impact of insurance premium on their household budget. Do you believe lower drug prices result in overall savings for Canadians on their insurance premiums if the new guidelines are introduced?
Yeah, there's no question that they will, and thank you for the question. Premiums are a function of the expected cost that we will be outlaying on behalf of an insured individual. So if those costs decline, anything we can do to bring those down will have a positive impact on premiums in the extent of reducing them. And for many employer plans, they bear the cost of the medication directly. We just administer those on their behalf. So it's an immediate and direct flow through. So I think this is why we're so supportive of these reforms. It's critical that we get the prices more aligned with what we see globally. It's going to free up capacity to even contemplate paying for some of these new medications. And so I think, it's really important that we get this done. We've been at this for many years now, and I think January 1's the date that we should be holding to.
Other questions to Ms. Fuller. You spoke about your work with the diabetes and access to insulin. As you noted, some drug manufacturers have tried to withdraw the less expensive insulin in favor of more expensive alternatives. Fortunately, the Canada Drug Agency proposed under the National Pharmacare Plan would negotiate the best prices possible and to keep affordable options on the market. Do you feel that the new regulation proposed by the PMPRB would effectively limit manufacturers from making decisions that prevent patients living with diabetes from accessing the affordable drug they need?
Well, I think that it can make to that. One of the things that the Price Review Board does is look at the evidence that there is a therapeutic advantage in newer insulin products, just like it does for any other drug. And if the guidelines are implemented and they are able, for example, to access better information and more information about which will allow it to assess whether or not the introductory price is a fair price, I think that will be good. Will the manufacturers say, sorry, we're not going to therefore introduce this drug? Well, Sanofi did that with insulin glargine, brand name Lantus. They were in a huge tug of war with the Price Review Board because the board looked at the evidence and said that that the evidence shows that this is not, I can't remember the name of the category, but it's not a drug that offers an increased therapeutic benefit. And so Sanofi got into a wrestling match. They did that in Germany. They did that in the United Kingdom. So it wasn't only in Canada that they were having this fight with regulators about what the fair and reasonable price was for that insulin. The Price Review Board basically, I think, caved in and relied on the assessment of the fairness based on what was going on in comparator countries. And of course, they're all higher priced comparator countries. So I think that with a change in the comparator countries, I think that's a very positive move. And I also think that I think that what needs to also happen is that the Price Review Board needs to rely more on the evidence. The comparator countries are important, but I also think that the evidence really is significant, should have greater weight in their decisions. I hope I answered your question.
Chair, how much time I have?
9 seconds.
Okay, I'll pass on. Thank you.
Okay, thank you, Ms. Sadu. Nous allons maintenant à Monsieur.
So now we're going back to Mr. Thériault. Please go ahead. And thank you. I'm going to put a question to Mr. Adams. You're an association that groups together several organizations representing thousands of patients suffering for various illnesses. At the last meeting, Mr. Clark suggested to the committee that several patient organizations cannot develop an independent point of view because they are counting on the support of pharmaceutical organizations. And I'll say there are many studies that show that when a person accepts money from another person unconsciously, that does have an impact on their opinion, even implicitly. And there is quite an obvious correlation between the position of patient groups about the reform and the extent to which they actually accept money from industry. Now, in your brief, you've deplored the fact that the patients have been pushed aside. And you've said that it's regrettable that the concerns and the lack of patient participation in this process has still not been taken into account. So on that affirmation from Mr. Clerk, do you not think that perhaps it's a little bit disdainful and perhaps even defamatory?
I appreciate some of the candor of Mr. Clark. And I don't go around looking for fights with anybody. But let me do an analogy. Among others, as well as being a patient and a patient advocate, I'm also a recovering politician. And so I'm not unfamiliar with the question of politicians looking for funding for campaigns. And we all have to govern ourselves with integrity when we seek and accept money for political campaigns. I don't think that's unique to municipal politics or to provincial, but applies to all levels. So one has to be careful about that. I think Mr. Clark might want, we look forward to a face-to-face conversation with Mr. Clark so that we could exchange in a full and frank way perspectives. I think he was unfair to many patient advocates and many patient organizations. I appreciate his candor on another point. He did acknowledge that the PMP has not done a study of the impact on research and development of the proposed new rules. I submit to this committee that that warrants is cause to pause and reflect before going full steam ahead, changing 4 different things at the same time. Thank you.
Croyez-vous que votre...
I don't have any time left. Thank you, Mr. Thériault.
Mr. Davies, 2.5 minutes, please.
Thank you. Mr. Adams, from the Best Medicines Coalition website, it says the Best Medicines Coalition seeks and receives corporate funding in the form of sponsorships and grants and receives in-kind support through collaboration and partnership from its member organizations. Can you confirm if any of that corporate funding comes from the pharmaceutical industry? And if so, how much?
Yes, actually in my opening statement, I confirmed that, sir. But happy to clarify. And our budget for the last 4 years has been about $220,000 on average. All right. And yes, we seek and do we seek unconditional funding from pharmaceutical companies.
So, Mr. Adams, and how much of that $220,000 or so annually comes from the pharmaceutical industry?
The majority of it, I don't have the number at the top of my head.
Could you provide that to the committee?
I'd be happy to. Thank you.
Thank you. Ms. Fuller, I'd like to ask you about the issue of the relative weight given to the evidence of improved benefit of medication and other factors like prices in comparator countries. And I'd be interested in your comments on how you think that should be weighed by the PMPRB in assessing adequate pricing.
Well, I think that issue of evidence is very important. The CADIS, for example, and the Therapeutics Initiative and other similar agencies in Canada look at evidence, and they assess whether or not the asking price is worth a recommendation to provincial drug plans to list or not list. I think that the Price Review Board should, if it had been looking and relying on the evidence for Lantus insulin, which is the example I use in our brief, I don't think that they would have approved a $5.50 per unit introductory price for that insulin if the evidence had weighed in the way that it should have. I've been involved in a lot of these issues around insulin. I've had diabetes for 52 years, so I've seen every single price for the last half century of insulin in Canada. When I was first diagnosed with diabetes in the late 60s, insulin cost my family about $1.17 per vial. And that insulin, the price of that insulin went up over the years to when it was finally withdrawn in the mid 90s, it was $11 per vial. But the price of newer branded insulins have gone up just incredibly, and they're no better than the insulin that I began using in the late 1960s. And I'm not saying that we should be paying $1.17 per vial, but the cost of insulin on the market today is completely unjustified, and the Price Review Board needs to be able to use better tools to assess whether or not those prices are justified. Excuse me. Now, insulin in Canada, the highest priced insulin is about $150 for a 7.5 ml amount. So, you know, these insulins are not providing, they're not lightening the burden on people with diabetes who use insulin, and they're certainly not lightening the financial burden of diabetes either. So I think that if the decisions at the board were made on the basis of evidence, that we would not be seeing these prices for insulin in Canada, or at least I hope we wouldn't be.
Thank you, Mr. Davies. So that brings round two of our questions to a close. We don't have time for a full third round. We have 20 minutes left. I'm going to try cutting the 5-minute slots back to 4 minutes, and the 2.5-minute slots back to 2 minutes, and that'll get us right in under the wire. And I'll be very brutal about the timing. So we'll go ahead now with Mr. Dontremont, s'il vous plaît. 4 minutes, sir.
I know we had a quick question there from Mr. McGuire. I don't know if Mr. McGuire is still showing there.
Yeah, I could, Mr. Dontremont. Thanks. Would that be okay, Mr. Chair?
Yes, go ahead.
Yeah, thanks. I know Mr. Adams in his opening comments made a reference to unwisely taking on unnecessary risks. I kind of made a note of that. Can you just elaborate on who's taking the unwise, or who is unwisely taking the unnecessary risks, and just what are his thoughts on that? Just expand on it.
Thank you very much. First of all, there's the regulations and there's the guidelines. The regulations were decided by the Cabinet of the Government of Canada, and the problem of the unwise combination of risks, doing 4 changes all at the same time, is baked into the regulations. So with respect, the principal point of accountability is the Cabinet of the Government of Canada. The guidelines are, it's the work of the PMPRB in how fine-tuning and how they would implement that. But they're taking their marching orders from the Cabinet. So short answer, the Cabinet.
Thank you. And to our witnesses from Boehringer, I know you do work with ventilators and COPD, lung cancers, that sort of thing. To tie it a little bit closer to COVID, I mean, maybe you can be responsive in this area. Our long-term care facilities, seniors are taking the biggest hit in Canada. 80% of the deaths are from that area. A lot of COPD and lung conditions that are fatal in this COVID. Can you just expand on how you see I think you made some plans about, you plan in generations and your Bridging Hope program and that sort of thing. I wonder if you could elaborate on that as to how responsive people would be have been during this pandemic in regards to trying to solve our situation, the biggest part of the disaster of COVID, under the present rules and perhaps under the changed rules. No, you're muted there, Ms. Boschman.
I'll start and Mahmoud
Thank
can
you.
complement. We work with the healthcare system in many different ways. We work with patients, with many stakeholders in healthcare. And of course, everyone has been committed to improving the situation, including ourselves. We did mention in our opening statement, we as other companies are working very hard towards continuing to provide better treatment options themselves. And so I think it's worthwhile to note many of our partnerships as well help the healthcare system. That's not factored into what the PMTRB would look at. Those go beyond even R&D investment. Our company is unique in many ways. We work with the system to improve system change. And so I think all of us are hard at work with this. And we're concerned that the PMTRB guidelines will in the future limit our ability to do that.
And Mr. Abhai, as well as you mentioned that you're working on digital health policy frameworks in that area. And would that be similar in that area as well? You're muted as well. There we go.
My apologies, honorary member. One of the things that we find that we are working with the Indigenous communities as well is, they are even more so challenged with regards to optimal access during a time of COVID. And just this morning, for instance, I had a discussion with Greybox, which is a Quebec-based virtual technology platform, digital platform, and an Indigenous group on how can we, Boehringer Ingelheim is partnering with Greybox, how can we bring Greybox into the picture with this Indigenous group that manages pan-Canadian optimizes diabetes care. So we just finished a discussion this morning. Exactly.
Thank you. I'm going to have to cut you off there. Sorry. We go now to Mr. Van Bynen, please. 4 minutes.
Thank you, Mr. Chair. And for those of us who are not too familiar with PMPRB, these conversations are always enlightening. So I thank you and our witnesses for joining the committee today and sharing their expertise. I know my time's been cut short, so I'll, even with the third highest drug prices in the world, the drug industry is falling short of its own 1987 commitment to invest 10% of Canadian revenues back into R&D to be performed in Canada. Current industry investments in Canada are 4% and falling. Annual industry investments in Canada would need to increase by $800 million a year to meet their own commitment, and by more than $3 billion to be comparable with other countries that they already receive the R&D in. The evidence suggests that pricing is not the main determinant of industry investments. And my question is to Ms. Fuller. She offered two alternatives. One was compulsory licensing and public manufacturing. And to what extent would this help in reducing the high cost of drugs?
Well, as I mentioned, when Connaught was when Connaught was manufacturing drugs in Canada, they provided those drugs at cost to public and private insurers and to consumers, and so obviously they weren't paying dividends to shareholders. They weren't raking money off the top and so forth and so on. So they were able to do that. The pharmaceutical industry is not able to do that. They have an obligation to provide a return on investment to their shareholders and so forth and so on. So I think that a public manufacturer would would go a long way towards contributing to a better cost picture in Canada for drugs. Compulsory licensing is a tool that Canada used to use and was also something that we abandoned during the period of free trade when we were negotiating free trade deals and so forth and so on. So these things have undermined our ability to not only have greater control over the prices that we pay for medicine and vaccines, but it's also undermined our ability to supply drugs to Canadians if the industry is not able or willing to supply them. And the industry right now is basically saying that they are not going to supply drugs, new drugs in Canada if the guidelines go through. And we're not the only country that they've issued that warning to. And so I think that one of the ways to respond to that, one of the ways to counter that, is to ensure that if they choose not to supply drugs in Canada, that we have the capacity to supply them ourselves. And we're looking at this now, or there's been a big debate in Canada around the COVID vaccine as another example. We're not making the COVID vaccine in Canada. We're relying on global manufacturers to supply them. And it's not that they're saying we refuse to supply you, it's that they're saying we'll get around to it, after we have supplied these other markets that we have obligations to or whatever. So I think that we need to figure out a strategy to deal with that.
Thank you. Now, according
Thank you,
to
Mr. Van Bynen.
Okay, thank you, Mr. Chair.
We go now back to the Conservatives. Is it Monsieur D'Entremont or is it Mr. McGuire or whomever? Mr. McGuire, please go ahead.
Yeah, okay, Mr. Chair, I just wondered, I know I had asked Mr. Alibi to elaborate on the issues that he was dealing with around the outbreaks that we've had on COVID in some of the Indigenous areas, and I wonder if he would have more to say on that. From being prohibited from expansion of these companies being able to work to solve some of these solutions in our own country. Or some of the problems, I should say.
As we shared with you, we are here today because we find the PMPRB consultative process to be ineffective. The feedback provided not by just us, by patient organizations has been ignored, as is reflected in the significant increase in the number of negative submissions on the guidelines when you move from the initial consultative process to the August timeline. So patient groups are concerned. The way BI, Boehringer Ingelheim approaches it is we are solution solvers. That's what drives us based on the opening. And we continue to work with Indigenous communities, with other partners to address their concerns and challenges. In effect, we are reconsidering a number of initiatives, a number of investments, because of the uncertainty and the unpredictability that these guidelines have posed. As I mentioned, we are the first company that negotiated a successful pan-Canadian negotiation. We built the system with the payers. We are committed to optimal, sustainable access for Canadians. And
thank you.
We find that the consultative process with PMPRB was not effective.
Thank you, yeah. Just a quick one to Mr. Frank, the Canadian Life and Health Insurance Group there as well. You mentioned that you hold the insurance for 99% of all the healthcare insurance programs in Canada. 29 million Canadians were insured. Does that mean that, what are we at, 35, 36 million Canadians now? Is it a corollary then that there's 6 or 7 million not insured under your programs? Or can you give me a more accurate number?
That's right. It would the difference would be those that would be on maybe on seniors programs in the various provinces or on some of the other provincial support.
But you're saying that you went on to say, I think that 87% value that coverage.
Yeah.
And so I wonder if you can just elaborate a little bit more on that, on how some of the pricing review changes would impact premiums and insurance companies and individuals.
Right.
Most
so
of it, I think, pardon me, I think you said that most of it is paid through their companies, but
correct.
You could elaborate.
Yeah, so the price of the medication is a pass-through from the insurer straight to the employer and straight to premium. And so any reduction in cost, any reduction in price would be passed through to the employer as who's the plan sponsor, or those who got individual coverage would see their premiums reduced.
But most Canadians, you're saying here, are very satisfied with the insurance coverage they've got.
No question. They're either very satisfied or satisfied. It's up in the 85% range.
Thank you.
Thank you, Mr. McGuire. I believe you're finished.
Yes, I am.
Okay, thank you. We go now to Monsieur Thériault. Monsieur Thériault, allez-y. Désolé.
Ms. Adams.
Mr. Adams, at the end of your brief.
Sorry, next is Mr. Fisher. I'm getting ahead of myself in the list. I apologize to everyone. Mr. Fisher, please go ahead. 4 minutes.
Thank you very much, Mr. Chair. To Mr. Thériault, didn't mean to stop him in midstream there. I want to take a second to thank all the witnesses who are here today, and thank you for your expertise. It's an interesting panel because we have diverging opinions. I want to go to Ms. Fuller if I could. And Ms. Fuller, this isn't really questions. I'm going to throw a couple things at you and ask you if you want to touch on some of these things. You made a comment with regards to supply, and you said government has the tools. It's unethical to hold back drugs from Canada due to regs. You said, separately to that, you said PMPRB needs the backing of Parliament. And then there was a comment by another witness earlier in the testimony that said drug prices in Canada are comparable to comparable countries. I wanted to know if you would just touch on 3 of those topics at your leisure. Thank you.
Yes, first of all, I think that although the industry feels that its overarching responsibility is to supply a return on investment to shareholders and so forth. From my perspective, the overarching responsibility should be to ensure that Canadians have access to safe and effective medicines. And that obviously is not at the top of the list. So Canada is not the only country that has confronted threats and warnings from the industry about in interrupting the access to medicines by patients. And as I mentioned in our brief, Global Insight, excuse me, I don't smoke. I don't know why I'm so gravelly. Global Insight pointed out that the human interest angle of patients being denied access to potentially life-saving therapies has generated an unusual level of support for a pharmaceutical industry often regarded with deep suspicion. And I think that what's happening in Canada right now and what has happened in other countries is horribly manipulative on the part of the industry. People are afraid if they don't get access to medicine. I am a victim of 2 companies that withdrew all of the only type of insulin I can use, which is animal insulin. And so, of course, it's a threatening and frightening thing when that happens. But I also do believe that governments have an obligation and a duty to counter those types of warnings and threats from the industry. And that's why we are arguing that tools that either are there or should be there, that government should develop those tools if they don't exist. And one of them is public manufacturing. We absolutely believe that that's to be the case. And compulsory licensing is another one. And also, quite frankly, national pharmacare. And all of those things are interconnected in one way or another. And the Price Review Board plays a very positive role in that discussion about access and affordability and justice, quite frankly.
Thank you. Are drug prices in Canada comparable to drug prices in comparable countries?
Well, I think that the Price Review Board has, that the countries that have been selected will enable us to ascertain where we fall within that range of comparable countries. And in the past, it seems the Price Review Board has sort of taken, has fallen midway within those group of comparator countries. I don't think that there's a huge difference in price between Canada and a lot of the comparator countries, which is probably not great. If we had lower priced countries, we would be able to bring our prices down as well.
And
thank you, Ms. Fuller.
Oh, that was quick. Thank you.
Nous allons maintenant.
We'll now move on to Mr. Theriault. I'm sorry, Mr. Theriault, for interrupting you earlier. You have 2 minutes. Mr. Adams, regarding uncertainty, regarding the authority of the board with regard to the implementation of their regulation, I'd like to hear you on that issue.
The problem is that this is about the Patent Act, but all of the arguments in favor of a PMPRB and the government doing are around what I would call consumer protection. The Patent Act is actually about regulating the use of intellectual property and avoiding abuses of it. That is not the same as consumer protection. So my quarrel, and I think the courts are going to deal with this, is that you can't, it's a bit of a stretch to push intellectual property into consumer protection. If the government of Canada and the Parliament of Canada see fit and say there's need for consumer protection around drug prices, I think that would require its own legislation, separate and distinct from trying.
I'm sorry, Mr. Chair. The interpretation services are having some trouble, but I'm sorry, Mr. Adams, but I'd like to be able to hear you. So, Mr. Chair, we need to go back because there are no interpretation services.
Oui. Mr. Adams, could you back up a little bit? We'll check with the translation to see if it's working.
Okay. For me, the key point and cause of uncertainty is the desire of some to stretch the Patent Act into a Consumer Protection Act. The Patent Act, in my view, is about regulating intellectual property and avoiding abuses of intellectual property. Its central purpose is not consumer protection. If the government and Parliament see fit that there is a need for consumer protection on drug prices, then with respect, it would be up to the government and the Parliament to pass a law on consumer protection on drug prices. And trying to...
Oui. Allez-y.
Yes, go ahead.
We're trying to fit a square peg into a round hole here. And I fear it's going to make things worse, and I fear we're heading towards substantial litigation.
2 seconds, monsieur.
2 seconds left. Well, I give them to you, Mr. Chair.
Merci, monsieur.
Thank you very much.
Mr. Davies, please go ahead. 2 minutes, please.
Thank you. I feel like I have to put a few points on the record. It's my understanding that the Patented Medicine Prices Review Board was created by the federal government after they extended patent protection to pharmaceutical companies, and it was a quid pro quo for the extended time that pharmaceutical companies would be able to have exclusive profit making for their molecules, which, by the way, a lot of research of pharmaceutical companies is done by them, but it's also a lot is done by public taxpayer dollars to universities as well. In exchange for that, there was a commitment by the federal government to control prices. So to Ms. Fuller, this committee has received evidence indicating that Canada pays the 4th highest prices among 31 OECD countries, 17% above the median price of those countries. Canada is the 2nd highest in the OECD in terms of how much it spends on patented medicines as a proportion of total healthcare costs and in per capita spending. Only the United States is higher in both cases. From 2014 to 2018, growth in spending on patented medicines in Canada has doubled that of GDP, and it's over 3 times the growth of inflation. So to you, Ms. Fuller, do you believe that the changes that the PMPRB is set to bring in will help to lower prices in Canada or not? And same question to you, Mr. Frank.
I think that they will strengthen the ability of the Price Review Board to ensure that the introductory price on drugs is fair. Yes, so my answer is yes. And I also do want to point out that the mandate of the Price Review Board is to basically, as you say, protect consumers from the impact of extended patents. So that there is a relationship between the patent period and the exposure of Canadians to unfair pricing.
Thank you, Mr. Davies. That brings our third round to a close. I'd like to thank all the witnesses for sharing your time with us today and for your excellent information. It will be a great help to our study. I'd also like to take the opportunity to note that our analyst, Karen Phillips, this is her last day on this committee. She is moving along to work with PHAC, I believe. I've worked with Karen for quite a number of years now, and she's been an enormous asset, so I'd like to thank her for that. And she's leaving us in very good hands as well. We have Sonia here, who will be taking over, and of course, Dominique as well. So thank you, Karen, for all of your great work and your great writing. And I'll hope that you can carry the message of the Oxford comma to your next location. So, and with that, we will suspend and bring in our next panel. Thank you all.
Thank you.
Whoever's taking.
Resumed. We are proceeding pursuant to the order of reference of Tuesday, December 1st, 2020, Bill C-210, an act to amend the Canada Revenue Agency Act, organ and tissue donors. We are starting our clause-by-clause consideration, and we will start by calling clause 1. We have an amendment on the floor, I believe. I believe Mr. Sobera wishes to move this. Mr. Sobera, please go ahead.
Good afternoon. Good afternoon. Thank you, Chair. I forgot to unmute there. Good afternoon, everyone. I believe, Clerk, you have received the amendment and been distributed to all committee members. I would like to, Chair, I'd like to speak that I will be obviously first moving this amendment on Bill C-210, and I wish to now speak on it. So thank you for everyone for availing yourselves and hearing me out for a few minutes. Firstly, it's great to be here, and it's great to be speaking on a bill that I know is very, very important to Deputy Weber, and I know it's very, very important to MPs on all sides of the aisle. And I'm very galvanized by that, and it is within that spirit that I present this amendment. It is to, in my view, at the end of the day, increasing the number of registered organ and tissue donors in Canada. I'm just going to read some prepared remarks for everyone. Thank you, Mr. Chair, for the opportunity to join your committee today as we look at this legislation that seeks to promote a cause that I think it is fair to say that all parliamentarians support, increasing the number of registered organ and tissue donors in Canada. This is an extremely important issue to assist Canadians in desperate need. It is truly a matter of life and death, so we need the best legislation possible. I know we all support the intent of this legislation. I do personally, and applaud the member from Calgary Confederation for his work and his desire to get this bill passed in the House and the Senate. I too am committed to advancing the bill's objective. That's why I'm advocating certain amendments to make Bill C-210 more workable for the Canada Revenue Agency so that it can be implemented as soon as possible. Hopefully, if Parliament can pass it quickly enough, that it would be in for the 2021 tax filing year. We need to ensure this legislation proposes the most efficient and effective way for the Canada Revenue Agency to collect this information and for the process to be efficient and useful for the provinces and territories who are ultimately responsible and within their jurisdiction for organ and tissue donation. As the Parliamentary Secretary to the Minister of National Revenue, I have made it a priority to examine this legislation in great detail and to discuss it with experts at the CRA who would be asked to implement it. I truly believe that this committee should hear directly from those professional experts at the CRA regarding this legislation, especially their experiences with the precursor legislation to Bill C-210 from the last Parliament, Bill C-316, and the CRA's interactions with the provinces and territories on that legislation, which occurred. Nevertheless, I am proposing and strongly recommended an amendment to make this legislation more straightforward for the CRA to implement with the provinces and territories, and also make it so that it can be implemented in the quickest fashion possible. This amendment does not change the objective of the bill, but rather the manner in which the objective will be achieved to remove potentially significant roadblocks and time-consuming delays. With this simple amendment, would do as such. Rather than having the CRA directly collect organ and donor consent on behalf of the provinces and territories, the CRA would collect and share the personal information of individuals wishing to become an organ and tissue donor with their respective provinces and territories, who would then obtain direct consent. The amendments accordingly would remove references set out in subsections 63.1 bracket 1 bracket and 63.1 bracket 2 bracket of the bill, which would make reference to returns of income filed under paragraph 150 bracket 1 bracket D bracket of the Income Tax Act. Rest assured, under this approach, a form would be included within the T1 return, both the paper format and in certified tax software, asking if the individual wishes to be sent information by their province or territory on becoming an organ and tissue donor. It should also be noted that the notice of assessment would still advise the individual that, in accordance with their request, their information has been forwarded to their province or territory as a potential organ and tissue donor. Once the information would be sent to the relevant province or territory, the province or territory would then be able to follow up with the individual on the actual consent to organ and tissue donation. This is an important and appropriate role for provinces and territories to undertake, as it is within their jurisdiction, as opposed to the Canada Revenue Agency, as legal requirements for donor eligibility and informed consent are very complex and vary greatly by jurisdiction in Canada, meaning different provinces and territories have different roles. By having provinces and territories play their proper role in obtaining consent, we are not only respecting their jurisdiction, but equally important, we are removing an obstacle by eliminating the need for protracted negotiations and complicated agreements with each of the provinces and territories on legal requirements for collecting the proper consent. With the amendment I am proposing today, our hope is that we would put the federal government in a position to reach more swift agreements with provinces and territories on a more straightforward, simple, and efficient approach, which I understand from CRA officials might need only months instead of potentially years to achieve. Again, and I repeat this again, we all want the objectives of C210 to become a reality, and sooner rather than later. But for the CRA to meet the earliest window of the 2021 tax filing year, so next year's income earned when you file your taxes of the year in January to March, or the period in 2021, the provinces and territories have to come on board, and we need to create the quickest path to make that happen. I would like to add, the approach taken here for the MPs that have been elected from the beautiful province of Ontario would be the similar approach to where information is collected for the what's called the Ontario Trillium Benefit, where a separate page is provided in the tax package, whether it is online or in paper format, and where the information is then passed to the province of Ontario. I am confident that our amendment today will do that and make the member from Calgary Confederation's objective a reality, potentially, and most likely, saving the lives of thousands of Canadians. Again, Chair, thank you for the time today to the committee. I wish to again applaud Deputy Weber for his efforts over the years in making this bill come to fruition and bring it this way. We are with you in the spirit of the bill, and I applaud your work on it, Mr. Weber. And I thank my colleagues for listening to me this afternoon. Thank you.
Thank you, Mr. Sobera. And I'll just remind members that to engage in the debate, they should use the raise hand function on the participants panel. And we have up next, we have Mr. Weber. Mr. Weber, please go ahead.
Well, thank you, Mr. Chair. And I do want to start off first by saying hi, everyone, again. It's good to be back in a HESA committee meeting. I served on it for 4 or 5 years, 5 years with you guys. And I miss it, but I'm now off on to public accounts. So that's quite interesting as well. Anyway, to speak on this amendment, Mr. Chair, of course, as all of you are likely aware, because I've sent you all a document indicating my thoughts on the amendments here, is that I just, in short, I just cannot support the proposed changes. The changes, it changes the scope, it changes the spirit of the bill, which is to get the initiative front and center on the income tax form. I want to talk a bit about the bill, the fact that it would not infringe on the provincial responsibilities of managing donor lists. It would just support their existing work. So my proposal, the way the bill is now, is so simple, and it could be implemented so quickly. The federal government, via the CRA, of course, already successfully shares every day with the provinces and territories via these encrypted networks with strong privacy and reliability safeguards. So the existing infrastructure is already in place so that it would be virtually no cost to the CRA. Now, the CRA already, of course, as you guys know, already shares dozens of data fields on information on every taxpayer with the provinces and territories, and this would simply be one more data exchange. So the actual proposal by Mr. Sobera, in my mind, and in many people's mind, would certainly just, change the scope of this entire bill. It would take it off where you can see it, and that is right on the front page of the T1 form. By moving the question off of the main returns of the income, it becomes a footnote, basically, Mr. Chair, becomes a footnote of irrelevance, and the effectiveness is dramatically reduced to the point of being basically pointless. It would allow the CRA to put the question somewhere less obvious, and it could even be as obtuse as asking people to file a separate form, which nobody would do with these amendments, Mr. Chair. You know, this issue came up in the last Parliament in the HESA committee here, and all the parties were clear about that they wanted the question to be on the front page. And the CRA was also clear about their ability as well to do this as requested and expected by the members of Parliament. So I want to ensure today that the CRA hears loud and clear that the expectations of Parliament is to have this addition made on the front page of the T1 tax returns in all provinces and territories. You know, this is déjà vu all over again. We covered the same issue back in the last Parliament. I testified at this health committee on the bill at the time was Bill C-316. And I said, I want to ensure that the CRA hears loud and clear that the expectations of Parliament is to have this addition made on the front page of the T1 tax returns in all the provinces and territories. I also want it made clear that we expect people to have the option to tick a box on that front page, which would be basically, Mr. Chair, a call to action. So, you know, I also have to indicate also that the CRA was at the meeting of the committee meeting, and it was made clear to them. And in fact, Sheila Bernard was at that meeting. She was with the CRA. She's responsible for the legislative changes affecting the T1 returns. And she testified, and she said that we have understood the intention of the bill to be on the annual tax return. Also, Mr. Frank Vermaidem, he is with the Canada Revenue Agency as well. He's the assistant commissioner. He was also there, and he was more direct in confirming our understanding, Mr. Chair, on this issue. And he stated the front page is certainly, yes, it's a crowded page, especially when you move into the French version of it, of course. But that being said, we believe we can put it on the first page. So that would be our intention. Even our colleague, Sonia Sidhu, also discussed a HESA, and she commented, she said, you said it's possible that on the T1 layout, we can have a tick box on the front so it can't be missed. That is the point here. If we allow this question or process to be buried, it will be ineffective, and I completely agree with her. And Mr. Chair, you yourself also had said that in our discussion, we have talked about the importance of this data capture appearing on the first page of the T1, but it doesn't specify anywhere in the bill, of course. Is there a way to ensure that this happens? And the CRA, Mr. Frank Vermaiden, said, I don't think there's a clear legislative way to ensure that this happens, but as I indicated, it would be our intent to put it on the front page. So the CRA at the time indicated that it can be done and that they were going to do it. And all of a sudden now here we are again, déjà vu. In closing, Mr. Chair, we have to simply ask ourselves the question, does the amendment that MP Cervera put forth, does that amendment strengthen the effectiveness of the bill and better improve the outcomes for those awaiting a life-saving transplant? I believe the answer is painfully obvious, and I would strongly welcome your agreement, committee, on this regard. You know, we have all worked so hard. I've worked so hard. Parliament has passed this unanimously up to this point. We have worked hard to make sure that this initiative has been unanimously supported, just as it was in the last parliament. So there are many people awaiting a life-saving transplant, and they will be bitterly disappointed if we wasted this important opportunity and buried the question on some form in the back pages that nobody is going to fill out. So let's show all Canadians that we are united and determined in our desire to truly improve Canada's organ and tissue donation procurement system here in Canada. So please do not support the proposed amendments. Thank you, Mr. Chair.
Thank you, Mr. Weber, and it is indeed good to have you back. We go now to Mr. Davies. Mr. Davies, go ahead.
Thank you. Well, I don't have a lot to say, but and I do have a question of clarification. But just in general, I just want to thank Mr. Weber again for being so determined and persistent in this bill. And I can say that I've worked with a lot of parliamentarians, and I said this in the House. I want to put it on the record here that there has been no more collegial or finer parliamentarian to work with in any venue than it's been with Mr. Weber, and his contributions to this health committee were incredibly important. So thank you. I also want to just second every single thing Mr. Weber said. I was privileged enough to serve on the health committee the entire last parliament, and I can vouch that every single fact and every single point that Mr. Weber just made is exactly true. So I won't belabor the points, just that it's, this is not just Mr. Weber's opinion. This is actually a very accurate recitation of what the evidence was. My question really is to Mr. Sorbera, because if I want to make sure I understand what the purpose of his amendments are, because it didn't strike me when I was listening to Mr. Sorbera's remarks that it is aligning with what Mr. Weber says the changes are. So, Mr. Sorbera, I'll ask you a direct question and feel free to elaborate if you feel necessary, but is it the intent of your motion basically to allow CRA to put the indication of whether someone wants to have their information forwarded to a province for potential organ donation anywhere on the form, including on a separate form or otherwise? Is that the main thrust of your amendment as Mr. Weber? So in other words, is Mr. Weber, is he characterizing your amendment accurately?
Mr. Sorbera, you may respond to the question if you wish.
Yes, thank you, Chair, and I'll try to be as succinct as possible. The intention of the amendment would be to have a separate sheet or page inserted into the tax package, that it would be within the contents of the tax package, where, for example, in negotiations with provinces, if a province wanted to have more information or less information with regards to the collection of information with regards to tissue and organ donations, that could be accommodated. If it was just solely contained on the first page of the T1 form, it would be very, very constrictive in terms of what's already on the front of the page of the T1 form. This would allow us, and as we know, the province of Nova Scotia has already opted out of this process with their own system, and please correct me if I am wrong, to my fellow parliamentarians. And we've also committed, I think it's $36 million over 5 years to improve the collection of data related to tissue and organ transplant. But as I said in my in my remarks, MP Davies, the page that would be inserted would be very similar to what is here happening in Ontario, where we have a separate page for what's called the Ontario Trillium Benefit, and that information is collected and then shared to the province of Ontario.
Thank you, Mr. Sorbera. Mr. Davies, were you done, or did you wish to continue?
Maybe just a little bit of a follow-up. The purpose of Mr. Weber's bill, and Mr. Weber can correct me if I'm wrong, is because of jurisdictional issues. And I remember when the NDP proposed, and I think MPs from all parties, I think at that one time proposed a national organ donation registry. The reason it can't be done, according to, I think, the Liberals, was because of jurisdiction. They felt that it was the jurisdiction of the provinces, which I think has informed Mr. Weber's bill, which means that what we're doing on the tax form is having each taxpayer check off a box that will authorize CRA to furnish the information, the name and the contact information, I suppose, to a province who is in control of organ donation, who would then contact the person and take it from there. If that's the case, and maybe I'd ask Mr. Weber to confirm that, it's going to be my feeling that we should stay with Mr. Weber's position because we want the most prominent placements as possible. And again, without belaboring the point, CRA said that although it was a crowded first page, it could be done, and they understood that, and they had the resources and the ability to do that. So, do I understand that correctly, Mr. Weber, that and Mr. Sorbera, that the really all the tax form is doing is indicating to the province that the person may want to have be available for follow-up. So that's why I'm not quite clear, Mr. Sorbera, on what else would be on this single form when that's actually the process that we're doing.
Mr. Chair, that is the case. The fact that the National Registry that was attempted by a colleague on the Conservative side years ago was shot down was the fact that the Liberals thought it was a provincial jurisdiction, which is fine, and why my bill came to fruition. Yes, Mr. Davies, all that is required by the CRA is to collect the contact information from the tax filer, name and contact information. That's it. You don't need a form. You don't need a form put on the back pages of a tax filing documentation system. It needs to be front and center. Otherwise, it will not be filled out. So, Mr. Davies, that's the information there. Thank you.
Thank you. Thank you. Did Mr. Sabor, did you wish to quickly respond?
Yes, just a quick follow-up. This obviously becoming a tissue and organ donor is a very, very personal issue for all Canadians. We want to make sure they have the proper information before making that decision, and I would encourage everyone to become a tissue and organ donor. Absolutely. With regards to the placement within the T1 package, so within the tax package, excuse me, it would be to use the characterization that it's going to be buried in the back and that no Canadian is going to see it, or it has to be placed right on the front of the T1 form. I do often think about in my role as the PS to the National Revenue Minister, when Canadians file their taxes, why they are doing that. They're doing that to obviously voluntarily to declare how much income they've made to pay taxes owing or to get taxes received, but also to get their benefits and credits back. So, which they obviously have worked very hard for and deserve. And I would say that that's within the mandate of what CRA is. We are now asking CRA to expand the scope of CRA's original mandate to also include this information collection to Canadians. I would say on that manner.
Je dirais donc.
Would be, if a province asked for further information or Canadians asked for further information in terms of why they were being asked to answer this, that it would be very prudent to have it on a separate page. So provinces could then get the information they need. Canadians can give the information and be confident. And we also remember 70% of tax forms are not prepared by the tax filer. And we need to ensure that Canadians have the information they need and that the provinces will be rest assured that jurisdictional issues are being respected. And
thank you, Mr.
I just wanted to say thank you to Mr. Weber. I understand this issue and I'm with you. Obviously, there's a view here that I've brought forward, and Len, I've reached out. We've chatted in conversations and stuff like that. And I just want to say thank you for explaining your position, and I do fully respect it. And the goal is to increase the amount of people that have signed up to become organ and tissue donors.
Thank you, Mr. Sabora. Mr. Davies, I don't know if you're done, but if I'd like to move on to Mr. Van Bynen. Thank you. We go now to Mr. Van Bynen. Please go ahead, please.
Thank you, Mr. Chair. And given the history, I've been struggling to support the amendment. If it's as a result of not amending the bill, there's a delay in implementing or an implementation, it's a trade-off with the effectiveness of where it is positioned on the tax document. And I am happy to say that I am an organ donor as a result of the process that was in place in the province of Ontario. But I will say that I will support the bill either way. But I do believe that the proposed amendments will improve the process and expedite the implementation. And for that reason, I'll support the amendment. But either way, I fully intend to support the bill. Thank you, Mr. Chair.
Thank you, Mr. Van Bynen. Mr. Fisher, please.
Thank you, Mr. Chair. Not on the amendment. If you could keep my name up for when we are past the amendment stage. Thank you.
Okay. I'll try to remember that. I'm actually, it gets too hard to keep track of, right?
Yeah,
Ms. Rempel Garner, please go ahead.
Thank you, Chair. I actually appreciate, I think, where CRA is probably giving direction to the parliamentary secretary on this amendment. But I think Mr. Van Bynen actually brings up a really salient point here, which is I think the amendment is being characterized as like sort of like this either or dichotomy, right? Like we either do this with a separate form, or we're never going to get this implemented in an expedient period of time. And I just I can't accept that. I think that, you know, in this situation, the will and intent of Parliament is supreme. So if we give direction, if Parliament gives direction to make this happen, with the intent being it front and center, rather than buried in some separate form, then then that's direction to the bureaucracy to make it happen. And I would rather that it happen properly than have it happen with limited impact. And I think that's really the trade-off that we're looking here. I think, you know, the spirit, my understanding of the spirit of the bill per Mr. Weber is to incent as many Canadians as possible to think about making this decision and actually do it. I don't think that having assistance in a tax form is going to somehow remove consent, because the whole, like, you actually have, when you submit your tax return, even if you have assistance preparing it, you're still obligated as an individual to review that information and sign off on it, that it's truthful, that you've disclosed everything. So, you know, you are actually involved in informed consent in the submission of a tax form to begin with. So I think that's a bit of a false argument. I think what's happening here is that perhaps the bureaucracy has given advice to the government that might make it easier for them to implement, but in doing so, it takes away the spirit and intent of the legislation. So I don't think that we can support the amendment while simultaneously supporting the spirit of the legislation, which is why I think we shouldn't support it. Now, with regard to the issue of provincial jurisdiction, in no way does the amendment remove the obligation to work with the provinces within their to make this acceptable within their jurisdiction. So again, I think that that's been a bit of a false presentation. This would still have to happen. At this point in time, the time period to get that done is really a matter of the minister giving direction and overseeing their bureaucrats to make this happen between the provinces and the federal government. So it's more of a matter of political will and efficiency within the bureaucracy than necessarily like just think. I guess what I'm trying to say is a statement saying, well, this is going to take years to happen, is really a timeline that's been given by the bureaucracy rather than, I think, by political will or direction. And I would like to think that on an issue that's this urgent and that could save this many lives, that we would see more political will. So again, the last thing is I think the parliamentary secretary had said that Nova Scotia had opted out. That's not actually correct. I believe they're moving to presumed consent, which is different than what was characterized. So I guess I would just implore my colleagues this, especially those from the Liberal Party, you know, particularly Mr. Van Bynen that just said this happened. I think it's more important that we support the spirit of the legislation rather than the pedantry of an approach, a proposed implementation approach that this amendment would, I think, in effect, neuter the spirit of the bill. So I urge my colleagues, we can respect provincial jurisdiction. We can, you know, give direction to the minister and to the bureaucracy to make this happen within the spirit that it's being proposed, and actually do something that's going to save lives. I strongly want to reiterate what my colleague Mr. Weber said. Having this buried as a supplementary form in the back, that the whole purpose of this bill is to have it up front so that people think about this and make a decision, that could save lives. Having a form that's at the back might make the lives of a few bureaucrats a little bit easier, but I would rather that we as Parliament give direction to the government and to their bureaucracy to make this happen in a way that we actually are saving Canadian lives rather than putting together a form. Thank you.
Thank you, Ms. Rempel-Garner. Mr. Barlow, you're up next. Go ahead, please.
Thank you, Mr. Chair. I won't take much time. Ms. Rempel-Garner's articulated very well much of what I was going to say, but I was not part of the Health Committee during the original debate, but I've certainly spoken to Mr. Weber on this legislation many times. And this amendment, no offense, Mr. Sorbera, but is a very big change from what all of us, all parties agreed to in the previous Parliament and has agreed to all along the way. So for the CRA to, and looking through the blues on some of the previous debates at Health Committee on this, for the CRA previously to say that this wouldn't be a problem, they have the wherewithal, the funding, and the guidance from Parliament to do this with that tick box on the front page, and then come back and and with a completely different position, I think is alarming. In that Mr. Sorbera's amendment, I know he has said that there would be a separate form as part of the T1 paperwork, but we have no assurance that that's what it would be. Would it just be, line 247 on your income tax return? Would it be an actual form that would be easily read and visible? What the essence of Mr. Weber's legislation here is have this on the front page of your tax return, that every Canadian will see. It'll be prominent, well displayed. The CRA agreed to do that. And no offense to the bureaucrats, but parliamentarians are the one who are supposed to be providing that guidance and that direction to the bureaucracy, not the other way around. The CRA could have brought these concerns up previously in the previous Parliament, or any time up until now, and the assurance that we had from the CRA previously was that this can be done, and it is doable and will be done. And now to come back with an amendment that Mr. Sorbera is being the messenger here, so I don't want to put too much on his plate, but there's no assurances for us as parliamentarians that what this amendment would, or where this message on the organ and tissue donor would be in the application. He's saying it would be a form, but we don't know that, because now they've gone from, yes, we will have this as a tick box on the front page, to, well, we don't really want to do that. We may, we can kind of commit to do this, but there's no assurances in the amendment that Mr. Sorbera has offered. I think it is so rare when we can work together as parliamentarians. And I know, Mr. Chair, you've spoken in my short time on this committee in strong support of Mr. Weber's initiative here. It is so rare when all of us as parliamentarians for different political stripes come together and put something forward that we all support, we all agreed to, we all worked hard to get to this point, and something that we know is going to benefit Canadians. And I just don't think it's right for bureaucrats within the CRA to say, what, it would be easier for us, or less work if we did X instead of what Parliament and the House of Commons has unanimously supported for us to do. And I think that sends a poor message to Canadians who Mr. Weber and many of you on this committee have worked with on this legislation, and they are looking to us to follow through on what we committed to do in the previous Parliament and what we have committed to do up until now. And just in conclusion, I guess I would say that I know how hard Mr. Weber has worked on this, and to get that support from all parliamentarians is something that I think we should respect and not change on the whim of the CRA, who again don't give us any assurance on what that will look like. And I think in the spirit of this legislation, I cannot support these amendments, and I would certainly encourage my colleagues on the committee not to support the amendments as well, and maintain what we had all agreed to over the past several years. And to get so close to the finish line, as I know Mr. Weber was so close in the previous Parliament, and that was a tough pill to swallow. And to get here again so close to the finish line and then get this this wrench thrown into the system, I think is really unfortunate. And I hope all of us can respect what we had agreed to before and not support these amendments and support the spirit of this legislation for the benefit of all of our constituents. Thank you very much, Mr. Chair.
Thank you, Mr. Barlow. Next up, we have Mr. Weber. Mr. Weber, go ahead.
Yes, me again, Mr. Chair. Thank you. I just want to make a couple of comments and a couple of questions to Mr. Sobera. First of all, his comments about his concern about expanding the scope of the CRA. You know, to me, these amendments would further expand the scope of the CRA by having them ask additional questions rather than just the basics, the tombstone data such as your name and your contact information. That's all that is required by the provinces. It's just a contact information of tax filers who are interested in registering in their provincial registries, their organ donor registries. That's it. You don't need a whole form for that. You need a tick box for the tax filer to just indicate that, okay, yes, the CRA will then transfer your name and your contact information. That's all that they require. Yeah, of course, that's when the provinces will then go forward with their forms in order to complete the process of registering the individual who would like to be registered. Now, you know, I want to talk about consultation. I know, Mr. Sobera, you of course have consulted with the CRA, but I've consulted with the CRA as well, but not only them, I've contacted the Trillium Gift to Life Network, the Canadian Blood Services, Kidney Foundation, the Canadian Transplant Association. These organizations want it front and center. They made it clear, and that's who we should be listening to, Canadians. So I guess my question to you, Mr. Sobera, through you, Mr. Chair, of course, is, you know, do you believe that these amendments, Mr. Sobera, will strengthen the effectiveness of the bill and better improve the outcomes for those awaiting a life-saving transplant? I'd like to get your answer on that. Thank you.
Thank you, Mr. Weber. I'm not sure I quite like the idea of tombstone data on my income tax, but we'll move on. Mr. Sobera, sorry, go ahead, Mr. Sobera.
Thank you, Chair, and thank you to all the MPs that have provided substantive feedback on their views, and I'm going to take this to on a couple levels, and I'll answer Mr. Weber's question because it's a very important question. Because to say that we're in favor of the intent of the bill, for me means that we're in favor of the effectiveness of the bill and the final result we get from the bill, which is increasing the number of people, individuals that have signed up to become registered tissue and organ donors, and that's got to be the goal of this bill, and this is a very, very important issue for many Canadians and for the organizations you highlighted. I would say it is, you know, there's always a balance in crafting legislation, in getting legislation done, and there's many stakeholders and many points of views with regards to. So, for example, I know Mr. Barlow commented, you know, what does it mean to listen to bureaucrats and other representatives? Well, we do need to take advice from our government officials and listen. Obviously, the final decision is with the government in terms of the direction, but it is pertinent and very imperative for them to provide that feedback to parliamentarians. It doesn't mean that we, you know, don't see issues or flags or say yes or no, but it is important to receive that feedback in this circumstance from the CRA officials. In my gut and in my honest estimation, in this process that I've been involved with in examining C210, I would like to see it along, as Mr. Van Bynen commented, at the end of the day, having the bill move forward. Absolutely. What I would like to see is a separate page within the tax package that clearly states and that we could utilize with the provinces in a very quick and efficient manner that says, you know, what can we agree with in the provinces and what information is handed, what descriptive information may be needed to be put in there. Again, I take it back. This is not simply just, if I can use the analogy, us asking people if we wish to pass on their information to be registered by Elections Canada. Elections Canada is a federal agency. We pass on the information to them. They then make sure that individuals are on the electors list, and that is on the front page. On this example here, there are jurisdictional issues. The opt-out by Nova Scotia, I know Mrs. Rempel-Garnell has commented on that. I'm going to take another look at that because I'm obviously open to constructive feedback and learning if I've erred in interpretation. Again, in terms of efficiency, effectiveness, and getting this in the tax package, the quickest way to do that is to have it on a separate page, not on the T1 form, but within the tax package. It's still there. It would still be for everybody to see. Everyone, we know when the tax filers are preparing their information is important to ask, and we need to ensure that Canadians have the information they need to make those decisions that are very personal in nature, including becoming a registered tissue and organ donation. So to Mr. Weber, very long way of saying, yes, I believe this still maintains the effectiveness of Bill C-210. Thank you.
Thank you, Mr. Sobera. We have again, Mr. Weber. Please go ahead.
Thank you again, Mr. Chair. Just a very quick comment on Mr. Sobera's comments. He talks about the quickest way to get this done is to put it on a separate form. I would beg to differ that the fact that, first of all, why would it take longer to put it on the front of the form than put it on the form? Are you suggesting that putting it on a separate form would then put it into the 2021 tax season? Yet if it was put on the front, it would take longer? I would say, first of all, why would you think that? Secondly, I would disagree. I don't know why it would take longer to put it on the front than it would to put on a separate form.
Speak through the chair, please, if you would mind.
Yep. All right. Okay. But anyway, that was my point there. Regarding the quickest way, Mr. Chair, I would say absolutely not. It would take the same amount of time. So, I guess I'm done now, and I guess I would just say let's just go to the vote. Thank you, Mr. Chair.
Thank you, Mr. Weber. Seeing no further speakers, I shall then therefore call the question. The question is, shall the amendment carry? Mr. Clerk, I would ask you to take the vote.
Mr. Fisher?
I abstain, Mr. Chair.
Mr. Kellaway?
I abstain, Mr. Chair.
Mr. Sobara?
I vote yes, Chair. Clerk?
Ms. Sidhu?
I abstain, Mr. Chair.
Mr. Van Bynen?
I vote yes.
Mr. Barlow?
I vote against.
Mr. Weber?
I vote against.
Mr. McGuire?
Against.
Ms. Rempel-Garner?
Against.
Monsieur Desilets?
Contre, Monsieur le Président.
Mr. Davies?
Against.
So we have yeas pour 2, nays contre 6.
Thank you, Mr. Clerk. The amendment does not succeed. So we move on to the vote on clause 1 itself. Mr. Fisher, I believe you wanted to speak to this. Go ahead.
I did want to speak to this, but Mr. Davies said exactly what I wanted to say. We have so many tremendous people in the House of Commons. Len, you are truly one of them, and I'm happy to support your bill.
Thank you, Mr. Fisher. Seeing no further speakers, I shall call the question. Shall clause 1 carry? Mr. Clerk, if you would conduct the vote, please.
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Sorbara?
Yes.
Ms. Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
Yes.
Mr. Weber?
Yes.
Mr. McGuire?
Yes.
Ms. Rempel-Garner?
Yes.
Monsieur Desilets?
Oui, Monsieur le Président.
Mr. Davies?
Yes.
So, Mr. Chair, we have yeas pour 11, 11, nays contre 0, none.
Thank you. The title, the clause 1 carries. Next question is, shall the title carry? Mr. Clerk, if you wouldn't mind.
Mr. Fisher?
Oui.
Mr. Kellaway?
Yes.
Mr. Sobara?
Oui.
Miss Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
Yes.
Mr. Weber?
Yes.
Mr. McGuire?
Yes.
Miss Rampel Garner?
Yes.
Monsieur Desilets?
Oui, Monsieur le Président.
Mr. Davies?
Yes.
So, yeas pour 11, 11, nays contre 0, none.
Thank you, Mr. Clerk. I should now ask, shall the bill carry?
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Sobara?
Yes.
Miss Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
Yes.
Mr. Weber?
Yes.
Mr. McGuire?
Yes.
Miss Rampel Garner?
Yes.
Monsieur Desilets?
Oui.
Mr. Davies?
Yes.
So, yeas pour 11, 11, nays contre 0, 0.
Thank you, Mr. Clerk. And that brings us to our last question, is shall the chair report the bill to the House? Mr. Clerk?
Mr. Fisher?
Yes.
Mr. Kellaway?
Yes.
Mr. Sobara?
Oui.
Miss Sidhu?
Yes.
Mr. Van Bynen?
Yes.
Mr. Barlow?
Yes.
Mr. Weber?
Yes.
Mr. McGuire?
Yes.
Miss Rampel Garner?
Yes.
Monsieur Desilets?
Oui.
Mr. Davies?
Yes.
So, Mr. Chair, we have yeas pour 11, 11, nays contre 0, 0.
Well, thank you all, and congratulations to Mr. Weber. And I would certainly like to thank everyone for your earnest and sincere advocacy on all the issues before us today. I see Mr. Weber has his hand up. Mr. Weber, if you would wish
Oh,
to
thank you.
speak, go ahead.
Thank you, Mr. Chair. And I just want to thank you all. I know I was a little bit passionate here today and a little bit, perhaps a bit emotional with respect to how I was speaking. And I just want to say that, I get that from, visiting these transplant units.
Félicitations, Monsieur Weber.
Congratulations to Mr. Weber.
I'm sorry. I'm sorry. I just want to say thank you, and even to you, Mr. Sobera. I know that you support this bill, and I just thank you all for supporting it when it does come to the vote. And yeah, I'm very happy with the outcome of today, and I just want to thank you. And I know that a lot of people who are waiting for that organ donation, thank you all as well. So thank you all very much, and have a Merry Christmas to everyone. Thank you.
Thank you, Ms. Weber. Mr. Sobera, please.
Yes. Very quickly, Chair. To Mr. Weber, I just want to say felicitación and congratulations on the work you've done on pushing this forward. It's a pleasure to have gotten to know you in the last week. I think this is the first interactions we've had, and it's been an absolute pleasure to chat with you and get to know you, and my best to you and your family over the holidays.
Thank you, Mr. Sobera. We go now to Ms. Sidhu. Ms. Sidhu, go ahead.
Thank you, Mr. Chair. Mr. Chair, I want to put on the record that on behalf of those who were served on the committee with you, we miss you, Mr. Weber, and congratulations. And then I just want to, you are the nicest person of us in the committee. And thank you all the work you did on the last committee and for this bill too. Thank you.
Thank you, Mr. Dew. Ms. Rempel-Garner, please.
For the slightly less nice person that replaced Len on the committee, from me to everyone else on the committee this year, I just wanted to say on behalf of the Conservative Caucus, thank you, Chair. Thank you to the clerk and the interpreters. We've got a lot of work to do in the coming few weeks and New Year, but this year has, I think, placed an inordinate amount of strain on everybody's walk of life. No matter where you are, what you do, this year has created challenges, and I sincerely hope that we can work together in the new year to come up with solutions for Canadians. But while we do sit in positions of privilege, I do want to wish you all time with your family as much as possible with the COVID restrictions, and some rest and relaxation before we hit the grind again in the new year. So Merry Christmas and Happy Holidays to everybody on the committee on behalf of the Conservative Caucus.
Thank you, Ms. Rempel-Garner. Mr. Davies, go ahead.
Well, thank you. On behalf of the large New Democrat caucus represented on this committee, I would also like to express my appreciation to all of you. I knew if we waited long enough, violent agreement would break out. So I know it takes time for a committee to gel, but I want to say that we have different opinions on things, but I never doubt the absolute goodwill and integrity and desire to make things better that comes from each and every one of you. And it's a real privilege to sit on this committee. And like Michelle, I want to just wish all of you the best of the season. And I hope you have a safe time with your families. I look forward to seeing you all in the new year.
Thank you, Mr. Davies. Mr. Van Bynen, please.
Thank you, Mr. Chair. It's been a very interesting and a good learning experience for me. I certainly appreciate having the benefit of many seasoned politicians on the committee, and that's been to my benefit. I very much respect and appreciate the deep commitment that brings all of us to the Hill and the genuine intent to make this country a better country for our citizens. And I truly appreciate the way that we're all working together. And I'm honestly looking forward to making some great progress next year.
Thank you, Mr. Van Bynen. Go now to Mr. Kellaway, please.
Thanks, Chair. And I may be the last one up, but I just want to share the sentiments here. I want to say thank you to each of the members, because as a newbie, you learn from your team, but you also watch and learn others in the committee work and how they ask questions and how passionate they are. And so to old members and new members of the committee, have a Merry Christmas, have hopefully a great rest, and we'll come back in January ready to rock and roll.
Thank you, Mr. Kellaway. Mr. Davies, your hand is up again.
I'm sorry, I was remiss in not expressing my deep thanks to Karen as well. It was not only a pleasure, but it was we were so fortunate to have Karen's excellent research and stewardship for this committee for the last 5 years, and I want to thank her and also wish her all the best in her next adventure.
Thank you, Mr. Davies. Mr. McGuire.
Just want to add my congratulations to everyone for the hard work they've done throughout this whole committee and the whole year, and take this opportunity to wish everyone a Merry Christmas as well. I spent a lot of years in Manitoba working across the floor with my colleagues in the Manitoba government and my own side of the house. And so this is nothing new to me, but I really appreciate the opportunity today and congratulate everyone on moving this Len's bill to the point where it's at. It's a bill for all of us, and I just want to wish everyone a Merry Christmas. Thank you.
Thank you, Mr. McGuire, and I'm going to take the last word here. I also would like to thank everyone for all their work throughout this past year. It's been well, interesting, and very, very useful, I think. So I wish you all a Merry Christmas and Happy Holidays, and I'd like to leave you with the words of Dr. Bonnie Henry: be calm, be safe, and be kind. Thank you all, and with that, we are adjourned.